Bismillahirrahmanirrahim. In the name of Allah, who is the victorious, the inspirer of faith, the absolute ruler, the most gracious, the most merciful. Dear colleagues, respected seniors, and our honorable guest of honor, good morning and assalamu alaikum. I am Dr. Saja Riaz.
And I am Dr. Hussain Ahmad. Allah the Exalted says, indeed, those who recite the book of Allah and establish prayer and spend in His cause out of what we have provided them, secretly and publicly expect a transaction that will never perish. The Messenger of Allah, Prophet Muhammad, peace be upon him, said, verily, the one who recites the Quran beautifully, smoothly, and precisely, he will be in the company of the noble and obedient angels. Ladies and gentlemen, this clearly shows us the importance of reciting Holy Quran. So, for the recitation of Holy Quran, I would like to invite on stage Dr. Yahya Iftikhar, please.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم والضحى والليل إذا سجى ما ودعك ربك وما قلى وللآخرة خير لك من الأولى ولسوف يعطيك ربك فترضى ألم يجدك يتيما فآوى ووجدك ضالا فهدى ووجدك عائلا فأغنى فأما اليتيم فلا تقهر وأما السائل فلا تنهر وأما بنعمة ربك فحدث صدق الله العظيم.
Subhanallah. The national anthem, like other national symbols of a country, represents the tradition, history, and beliefs of a nation and its people. It helps evoke feelings of patriotism among the country's citizens and reminds them of their nation's glory, beauty, and rich heritage. Now, I would like all of you to rise from your seats in the honor of national anthem. Please.
It gives me an immense pleasure to extend to you all a very warm welcome on behalf of Colorectal Disease Patient Welfare Association and Organizing Committee. We welcome you all to the first day of 6th COLOCON 2022 at Pearl Continental Hotel. Today, the sun shines brighter, but not without a reason. It is a sunshine after a long, clouded, gloomy period of 2 years.
We are indebted and thrilled that you all have decided to take part in the juncture amongst the world's leading experts in the field of colorectal malignancy, management, and recent advances at COLOCON 2022.
As the famous saying by Eddie Izzard goes, they say the universe started with a big bang. I hope everybody stood well back, because this COLOCON is back with a bang of scads of knowledge. Ladies and gentlemen, let us start by elucidating the importance of this conference. So, Dr. Hussain, can you please throw some light on the prevalence of this colorectal malignancy's prevalence worldwide?
Yes, today about 5.2 million people worldwide are living with colorectal cancer, and it is now second most deadly malignancy worldwide in both men and women. Early detection, screening, and pertinent treatment are the cornerstones of managing colorectal diseases. A gradual shift towards right-sided or proximal colon cancers has been observed internationally, with the greatest relative increase in incidence in cecal primaries. And with the passage of time, the prevalence of this disease might increase.
Hence, we can understand the immense necessity of awareness among the population regarding the recognition of early signs and seeking timely management.
Ladies and gentlemen, as William Shakespeare said, "What a piece of work is man, how noble in reason, how infinite in faculty, in form and moving, how express and admirable. In action, how like an angel, in apprehension, how like a god. The beauty of the world, the paragon of animals, and yet to me, what's the quintessence of dust?" I am profusely elated to take an opportunity to invite Professor Mujibur Rahman, the chairman of Colorectal Disease Patient Welfare Association. He graduated from Sindh Medical College in 1989. He acquired fellowship in general surgery from Royal College of Surgeons, Ireland. He obtained his laparoscopic diploma from European Institute of Telesurgery, Strasbourg, France. He joined LUMS as an assistant professor of surgery in a newly established center, Laparoscopic and Minimally Invasive Surgical Center in Public Sector Hospital, Jamshoro. He provided services for almost 10 years and then joined Dow University of Health Sciences as Associate Professor of Surgery in Colorectal Ward, Civil Hospital, Karachi. He then excelled in his career and promoted to Professor of Surgery and retired in 2022 on the completion of his superannuation. Ladies and gentlemen, allow me to call Professor Mujibur Rahman on his stage for his opening address. Sir, please.
Assalamu alaikum everybody and good morning. It's an honor to be in front of you. It's a pleasure to welcome you all and the guests from abroad also for this very auspicious occasion of 6th COLOCON this year. It was very difficult and challenging to restart COLOCON after 2.5 years of COVID, still which is lingering on. But then the idea was that we should continue because this pandemic will be with us for as long as we can remember. So the life should go on. So we decided that we'll restart again. Though there will be few hiccups during this endeavor, but I hope that we'll be able to properly conduct it and finish it. The idea of CDPWA, which is basically a short form for Colorectal Disease Patient Welfare Association, was coined by founder chairman Professor Amjad Raj Mehman, and then started working on that one, and the CDPAW was registered about 9 years ago. This is our 6th one. Since then, we haven't looked back, but still continuing to walk on and achieve the goals we set for these colleagues, the junior surgeons, and our pivotal center of our efforts is our patient. We are, though, still having few problems regarding, because it's a public sector hospital, so we do know that what it entails to come to the public sector hospital. But still we are providing them free of cost the surgery, all radiotherapy, chemotherapy, and even we look after our patient once they finish the surgery and go home and come back to us, even providing them with the stoma bags and all those things, though it is becoming more expensive for them, but we are still trying to help them as much as we can. Regarding this COLOCON, it gives us understanding that what the new ideas and techniques and the gadgets we are getting, as we couldn't think about robot about a couple of years ago. Now we are having the robotic surgery, which I can understand that is as good as anywhere in the world, though even the NHS cannot have so many robots as we have in, mashallah, in SIUT and in civil hospital, though it's very costly, but then it gives good results, and we are providing the same services as anywhere in the world could be. It's very tough task to live with the colon cancer, but then on the other part of that is the training and having these gatherings, which basically is more for us to discuss the new strategies, the new techniques, and the new studies which come out. So hopefully you will have enough time to discuss among your colleagues, the people from here, different parts of the Pakistan, specialized centers for the cancers, and our two distinguished colleagues from abroad, from UK, and we'll be more than happy to see you people interacting with each other, and hopefully you will enjoy these sessions for today and tomorrow. And those who were involved in the hands-on surgery and in the live surgery, hope you have enjoyed that one. So thank you very much for your coming. Thank you.
Thank you, sir, for your inspiring words.
Now, I would like to invite Dr. Lajpat Rathore, who is working as a senior resident in Civil Hospital, Karachi. Sir, please come on stage and enlighten the audience with the audit of colorectal cancer surgeries in Civil Hospital, Karachi.
Hello. Please start the PowerPoint. Hello. I will be presenting the colorectal cancer patient statistics in our ward, colorectal ward, CHK Civil Hospital. So, ठीक है, कहाँ से, यहाँ से होगा, वहाँ से होगा, अच्छा सही, ठीक है, सही. So this is statistics from this running year, from January 2022 to November 2022. The total number of patients received during this year was 180. It is continuously increasing. We have the previous figures. The distribution of colorectal cancer in our population is bit increasing toward the younger population. That is, we have received even 9-year-old patient with the rectal cancer. There are total 18 patients less than 20 years. And the major chunk is between 20 to 40, that is 63, and between 40 to 50, 39, and between 50 to 60, 34, and above 60, 26. So sex distribution, the 59% found among the male and 41 in the female. The positive family cancer, any cancers positive among these patients was 10% in the family. These are the complaints that patients were presenting. That is, bleeding PR was found in 74% of patients. The constipation 84%, diarrhea 26%, and 57% is the weight loss. And smoking association was 23%. Here's the number of cases per year. It's continuously increasing. So there was a major break during COVID. We have received a lot of patients, and then it continuously increasing. It was 39 12 2015. That is continuously increasing. And the 2020 it was 153, and the 2021 168, and this year running year 180. The surgical procedures done in our unit. In the 2022, we have done lap-assisted APR4 and the open APR27. In the anterior section, lap 8 and open 28. And the Hartmann 14, and laparoscopic right hemicolectomy 4, open right hemi 15, left hemi 6, and this diversion for covering are either before sending new adjuvant, that was 24 and 37. The site of tumor distribution, the here major chunk lies in the rectosigmoid and rectum. The 89 patients in the rectum, 29 rectosigmoid, 17 sigmoid colon, and 19 ascending colon, and 5 anal canal, and the rest. We usually see patients at the advanced stage. That is stage 3 or 4, that is Duke stage C or D. The major chunk in the stage C, Duke C, that is 54. We have already. The tumor biology, the major chunk is adenocarcinoma, though we have received these rare cases, that is neuroendocrine, rhabdomyosarcoma, malignant melanoma. The malignant melanoma has increased from last 2-3 years. That is, we have received 5 in this year and 4-5 in the last 10 years. So we have around seen 15-16 patients of the malignant melanoma of anorectum. In the rest, the moderately differentiated adenocarcinoma has 76, and moderately differentiated adenocarcinoma with signet ring, that is 27, and poorly differentiated 37, and poorly differentiated with signet ring, that is 16. Now come to metastasis. This is the presentation, patient present to us at this stage with the 20% peritoneal metastasis, 12% liver metastasis, and 5% lung metastasis. That's all. Thank you.
Thank you, Dr. Lachpat. Thank you, Dr. Lachpat. As Hippocrates once said, where the art of medicine is loved, there is also a love for humanity. Within the past 2 decades, minimal invasive surgery has become an incredible advancement in the field of surgery, and it has led to so much innovation in cancer treatment. Instead of surgeons placing their hands inside the patient to perform surgeries, laparoscopic surgery has enabled surgeons to perform complex procedures through small keyhole incisions.
Ladies and gentlemen, today we have gathered some great minds and highly skilled laparoscopic surgeons under one roof to educate with their experiences. And to start our first session, I would like to invite Dr. Omer bin Khalid. He is Assistant Professor of Surgery in Civil Hospital Karachi and Consultant Surgeon at Secondary Hospitals and IMS Clinics of Aga Khan University. He completed his MBBS in 2008 and cleared FCPS in 2016 and is also fellow of American College of Surgeons. He has also worked as an instructor surgery at Aga Khan University Hospital. Sir, could you please come on the stage to lead the first session of the day? The theme of the first session is colorectal surgery today.
Thank you so much for a very nice introduction written by me. I'm truly indebted and obliged to the organizing committee for providing me this opportunity to share the stage with such renowned surgical faculties. Thank you. So let's start this session. I'd like to introduce my panel of experts. Professor Shafiqur Rahman. Professor Shafiqur Rahman is considered amongst the pioneers who introduced laparoscopy in Pakistan way back in 1990s, and he also has the honor of doing the first laparoscopic APR around the globe. He retired as Professor of Surgery, Dow Medical College in 2010, and then he continued his services as Head of Department Surgery at Dr. Ziauddin University Hospital, Karachi. At present, the professor serves as an honorary-led General Surgeon and Surgical Oncologist at Baitul Sukoon. Sir, I welcome you. My next panel of experts is Professor Mohammad Zubair. Professor Mohammad Zubair is Professor of Surgery, Medical Educationist, and a researcher. He's currently Head of Surgical Unit 2 at Civil Hospital, Karachi, and also Director of Distance Learning and Online Teaching at DUHS. The professor's prime interests are in robotic surgery and health professionals education. Sir, I welcome you on board. My next panelist is Professor Razak Sheikh. Professor Abdul Razak Sheikh is a general surgeon, medical educationist, administrator, and researcher. Served for more than 25 years at Liaquat Medical University as faculty in surgery, and he holds the award for Best University Teachers from HEC Pakistan. Professor Razak has also served as Sindh Healthcare Commissioner from 2019 to 22, and at present, the professor is serving as Registrar CPSP and has more than 80 scientific publications to his credit. My next panel of experts is my teacher, Professor Inam Paul. Professor Inam Paul is a consultant surgeon, researcher, clinical professor, and faculty of surgery at Aga Khan University Hospital since 1995. He holds 36 original publications in Index Journal and has prime interests in GI oncology. The professor has teaching interests in undergraduate and postgraduate training. My next panel of expert is Dr. Irfan al-Islam. Dr. Irfan al-Islam is a consultant surgical oncologist at Shaukat Khanum Memorial Cancer Hospital and Research Center. He holds fellowships in advanced robotic and laparoscopic colorectal surgery from Champalimaud Center at Portugal and Norfolk and Norwich University Hospital, UK. Sir, I welcome you. So this session is a 90-minute session which I promise would be intellectual and excellent for all my colleagues and juniors especially. I've got great speakers. The first one I would like to introduce is Dr. Rao Khalid Mahmood. Dr. Rao Khalid Mahmood is a laparoscopic surgeon with an experience of more than 700 laparoscopic colorectal resections with excellent results audited locally and nationally in England. At present, Dr. Mahmood is working as a substantive consultant at Barnsley Hospital. Dr. Rao Khalid Mahmood.
Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Thanks for inviting me on such on a prestigious platform to talk about. I'm sorry, I got a bit sore throat. So if you put the slides on, please. So as you heard in the intro that I'm working substantively at Barnsley Hospital, but currently I'm on employment break here in Pakistan for a year, so it is nearly that's my 6th month in this country, especially in the city. So what I'm going to talk about is primarily what I have noticed. So this is a personal repertoire. It is a personal analysis of the challenges which I faced in this country in the last 5-6 months. So they are not validated claims. They are just, I've discussed these kind of analysis with my friends, with the surgical fraternity. So you can call them as anecdotal, evidence-based. So, and I got a few solutions, which I think the whole idea is to talk about, at least to start the debate, to initiate the questioning. So that's me, and let's start with the first slide, please. Next slide, please. मेरे पास है point. So the challenges which I faced, कौन सा दबाना? Okay. So the challenges which I've analyzed or faced, the challenges with the awareness, with acceptance, with apathy, with absenteeism, with this is not the challenge, this is what we got in this country, abundance. But we need to ascertain where we are going and how we need to accomplish. So the idea is, we have heard about in this session what exactly we are doing in this country. We have heard about this audit as well. And you have seen that in the previous sessions of COLOCON, the advanced laparoscopic surgery, but this is my personal repertoire. So COLOCON, as you know, you heard about COLOCON very well, that this is a great effort of Professor Amjad Siraj Memon and his colleagues who made it possible with the patron-in-chief, Professor Saeed Qureshi, Professor Naved and others, and my dear friend Khurshid Sammo. So, and you heard about it, so I'm not going to talk about COLOCON further on. So what I have noticed working in this country, I found the issues of awareness about laparoscopic colorectal surgery, whether it is for the cancers or for the benign diseases. Public is not very much aware of this new technique. We have talked about that probably in the 5-6 days of COLOCON, whatever the number of days we are here. and tomorrow will be here as well. We talked about screening, and probably the speakers after me will talk about that as well. But I found that awareness about the screening is still lacking, and the importance of screening is not very well understood by the nation or by the medical fraternity. Then what I've noticed working in this country, that the trainees are not very well versed. They are lacking the true understanding, even the senior trainees, what the laparoscopic colorectal surgery stands for and how we do it, whether it is for benign or it is for cancers. Forgive me, it may be a tall claim, but that's what I have noticed. You can debate about it. I'm going to say, with due respect, I think the senior surgical fraternity, if may be more supportive to create the better understanding among the public and among the junior surgical fraternity who's going to take over from us in near future. So now, what I call acceptance and apathy, in my view, you've seen Professor Cheema and Professor Taz Qureshi and others operating on these wonderful machines, Da Vinci, which is even the SI, not even XI. And we know that they are the stars of their time. But the point is, the laparoscopic surgery needs acceptance, rather the robotic surgery. Robotic surgery is becoming a norm in England as we speak in this part of the world. However, what I've noticed that if the laparoscopic surgery is the norm in the other parts of the world and robotic is becoming the new standards, is this norm a norm in this country or not? We need to ask this question from ourselves. And what I call apathy, if the new techniques are basically being norm in the other parts of the world, and if someone can't do it, we should not be probably declaring it's not working. That creates apathy to the new technique. It may be a tall claim, it may offend someone, but that's what I've noticed, forgive me. It may be politically incorrect slide. What I call absenteeism. So the public, as I said, is lacking education, but we need to ask this question very honestly to ourselves. Are we educating our public about this new technique, whether it's laparoscopic colorectal or it is robotic surgery or any other new techniques? And the other claim which I heard that the cost of laparoscopic surgery is very high. I think we need to talk about this cost. We need to talk whether we are calculating the cost of laparoscopic surgery only during the index admission when the patient is operated, as this country is mainly run by the private sector rather than the state sector. Although, as we listen that we are doing the state-owned hospital surgeries in Dorset and other hospitals. So the cost of laparoscopic surgery is not for the indexed admission only, it is in the long run as well. What the patient is having with the long cut and what's the quality of life and the patient's life afterwards and their cost which they are going to bear with the open surgery. We do have MDT culture in this city. I'm going to which I'm specifically talking, but we need to ask this question very seriously with us: is that MDT culture is flourishing and taking roots, and are we taking the MDT decisions on board and operating our patients according with the MDT advice? These are my thoughts. I'm not saying that this is not happening, but this is what I think we need to ponder around a bit more. We heard about secondary hospitals, but we need to think about these tertiary referral centers. Are the concept of tertiary referral centers is taking roots on or not? Because it's very important. You'll see in my next slide what is the concept of tertiary referral center and why I'm talking about it. What this country is blessed with. This country is blessed with huge human resources, massive, massive amount of doctors, huge amount of doctors are graduating each year, going into their FCPS training. After 4 years, they are coming out. Massive amount of capital. We talk about that the patients are poor. Yes, we know that. But even then, on the other side of the river, there is, other side of the bridge, there is huge capital. This is maybe distribution, maybe not correct. Patients. I've heard when I was coming to Pakistan that the colorectal patients, colorectal cancers are not that much as in England. But honestly, I've seen huge number of colorectal cancers in this country, and as we've seen the slide in the audit as well, the numbers are increasing. Infrastructure is huge here. Every hospital claims that they are doing laparoscopic colorectal surgery and advanced colorectal surgeries. Policies and controlling bodies, endless. But the thing is, as Walter Disney said, the change, what I'm going to talk about in the next few slides, only happens when we stop talking and doing things. If these are the right claims, if these are the right questions, when we ponder around then, I think we need to bring some solutions out as well. We need to accomplish few things. What we need to talk about. I'm not going to specifically talk about the training program in this country, but because I see this is my personal analysis, as I said before, and these ideas I brought out after my own analysis in general, what's happening in the country and how we can fix probably. So the first thing is the new breed of surgeons who are coming and will be the vanguard of the surgery and taking flag over from us. Let's look at the training scheme in the other parts of the world. The length of postgraduate training scheme in United Kingdom and Ireland is more or less stands for nearly 10 years. This is before the specialist training. You got a core training, the internship, core training, and the specialist training. And every country is probably roughly 6 years, United States and other years. Only Colombia stands for 4 years. The minimum numbers of surgical procedures you need to produce your logbook as a trainee. United Kingdom and Ireland stands for nearly more than 1,500 cases, which should be validated. The logbook should be validated by trainers. And in the last 2 years of training, the DOPs are done. They are validated cases by the 3 different consultants that you can do a APR, and that has been DOPed, and that's been seen. So the other, if you want to go with the lower number, South Korea only needs 64 cases. I don't know what these 64 cases are, appendix or something, God knows, but that's what the paper says. So this slide is about volume. That is the slide about my previous slide, which I said, the tertiary hospitals. This is about volumes, and it speaks volume in itself, to be very honest. I put the gastrectomy, which more or less every general surgeon is doing it here. Look at the slide, the low surgeon volume, 895 surgeons operating on 2,336 patients. One patient is getting nearly less than 3 patients per surgeon, and the mortality is 12.2%. And then it goes to the high surgeon volume. This is the concept of tertiary hospitals, which I was talking about. Every hospital in this city is doing more or less everything. 91 surgeons have operated on 2,281 patients. The mortality is 4.3%. So this slide speaks volumes. So you can see that what's the difference is. There is a score called CUSUMS score, cumulative sums score. And this is, I've took only the mortality, which is obviously the end result for the surgeon and for the patients. I could have spoken about the anastomotic leak, about the quality of life, about post-op complications. I didn't pick that. I picked the last thing, which is mortality. Obviously, it is not only for me and for surgeons and for you as well as a surgeon, which matters. The other chart on the slide is for all of us. We talk about the numbers, we talk about the learning curve, we talk about how we can make ourselves better. Again, the volume. See, this is the linear representation. The number of cases you're going to do, you're going to get better. The more, the English proverb is, more you're going to do, more you're going to get better. Very simple principle. So if you see the quality on the one side, on the longitudinal axis, if the number of the patients are less, obviously your quality will be poor. As soon as the number of the patients increases, your quality will get better. The quality here comes with each and everything. So, and there in the middle point, which is a surrogate point, which is a threshold, you can calculate by, the local surgeons can calculate by themselves. In England, it is 20 patients, the 20 cancers a surgeon must need to do, keep his skills annually. So that is more or less the same numbers as I put in the high surgeon volumes, 25 cases per surgeon. So you can see this is the most important way of going for the tertiary hospitals and getting the best results. What I've noticed about these tertiary hospitals and bringing this new breed of surgeons who can change the country's map, the paradigm shift only can happen if we need to have a leapfrog. We need to bring the young, energetic, trained surgeons, in my opinion, from overseas, who needs to take over the reins and train the local surgeons here. The local training system is good, probably, but we need to have more hands-on people from abroad so that we can be at par with the international community. So the choice is yours. The laparoscopic surgery, which was holding the emblem and holding the beacon, is still holding the beacon, but believe me or not, in England, I can talk only about England, is dying, whether you like it or not. It's robots which is coming in laparoscopic colorectal surgery. So it is your choice whether you want to laparoscope, you want to be laparoscopic country, you want to be robotic country, or you want to be an open country. It's entirely your choice. The world is changing. We need to embrace the change. If you need to embrace the change, we need to think very differently. Thank you very much. Any questions, I'll take.
So, just point out what are the main difficulties in which we can go and start improving on them. Because, yes, our trainees are not so well trained. We don't have a structured training system. And at times you feel lost that you want to do something and your assistant is not coming with you, and so many things. So because you have just recently come back, if you point out those particular points which we can improve upon, would be good for us.
So in my opinion, as I said before, so in a structured training system, we can only produce the trained trainees. So the best thing would be, given the circumstances, I personally believe the hospitals, which are the teaching hospitals, they need to induct people who are more trained, and they need to be given this responsibility to train rather than to shine himself or herself. This should not be a personal kind of, the program. It should be a national program, and these people who are brought here, they should be brought with one point, one agenda only, that they're going to train the new generation of surgeons. And they need to have this kind of feeling that they are here to train rather than to exalt themselves. That's the way forward, in my opinion. Please.
I'm from College of Physician Surgeon, Pakistan, and This college has started this structured training program in more than 80 disciplines as a primary, first fellowship and second fellowship. And we believe in competency-based medical education, and definitely it is well-structured program. And we are also starting from January 2023 and primary second fellowship in colorectal surgery. And this is, if you will look at our curriculum, and this is very good. And definitely we are training our trainees not on the patient but on simulators. That's our good achievement.
That's very
Thank
nice. Good. I think it's a way forward to bring a further super specialization as we do the subspecialty training in England in colorectal upper GI. That's the way forward.
Any questions from the audience?
Dr. Rao, thank you for a thought-provoking presentation. I've been back in this country from England for the past 28 years now. What you allude to conceptually seems fairly intuitive, to get trained people, borrow from outside, and things will get better. But if I look at the reality of my country, this philosophy has been tried again and again and again and failed every time. Look at education, look at democracy, look at our police, look at our roads, look at the traffic. Everything has been borrowed with this concept that things will get better because they're being done better abroad. Nothing seems to work.
Very true.
I think there's a fundamental flaw, and that fundamental flaw lies in our thinking and our approach to life and such. I think the people living in this country, and by that I mean the professionals, I'm talking about this particular group of people right now, have to really have some introspection, acknowledge that we have failed massively, and the reason for our failures is ourselves, and that needs to be put right. We cannot rely on people coming from outside, bringing a magic wand and fixing our problems. It has to be done from within the system. The system has 220 plus million people in it. What you're proposing will train maybe 200 surgeons, maybe 50 surgeons, I don't know. But that's not going to affect the problems that are faced. Robotics and laparoscopic might be the way forward right now for Western countries where this is doable. But I don't see this happening in Gujranwala or some small city in Larkana or some small hospital in Larkana. This is always going to be in these larger few hospitals which will predominate, and individual surgeons will become, show-offs, declaring their skills. That's what we've become. We've become show-offs. We are flouting our skills, individuals showing off how much they can do and really not affecting the system at large. That is what needs to be addressed. Thank you.
No,
I may like to say something what Dr. Inam has said. I think this is a ground reality. We people have a lot of egos and very little skills, and we just try to pose as if we are the world and we know everything. But there should be a change in attitude, and it is us who are going to bring the change. When I came back from England, my professor had a colonoscope and endoscope lying in his cupboard, but I was not allowed to touch it. And when I became a professor, I wrote a letter to every unit, medical and physical and surgical, that there's an endoscope over here. Whoever wants to learn, whoever wants to do, come and do it. So we have to change things, and it is us who are going to change the things. So we should work on it together, and I think the change is going to come. Thank you.
Just only one thing I want to say about Professor Inam Pal's comment. He's exactly said the same thing which I said in the previous slide. The individuals can be show-off. They can basically tell the nation that they are the star surgeons. That concept must need to die if we want to live as a nation. If we're actually a nation, I don't know whether we are just a mass hujum or a nation, I don't know. But the point is, Professor Inam Pal he has done a very nice analysis. I think he wants to bring the solution out of this nation, which should be indigenous, to be very honest. Bringing imported Wazir Azams and bringing important democracy and everything, which definitely is not going to work. But we need to look very, very seriously as a nation. Forgive me, I'm just only an individual, but look at your nation and the people who are coming behind you. When you will be here, I will be here. If we are in this country, we will be operated by these surgeons which are getting training at this point of time. So you need to think very seriously. So the nation primarily needs to sort out how it's going to sort it out itself, to be honest. The trained people from not outside are coming. There are 2 or 3 people sitting in front of you, and they have operated in the last few days, and they've shown you, demonstrated you how the things works in the other parts of the world. So this is basically raising the standard, raising the awareness. That's the way, in my opinion, in my slide I said leapfrog. Professor Saab said that it's been tried in the past. I think it may have been tried, but it should be tried with a different vision. But if you think the local solutions will work, definitely let them work. The whole idea is that the national standards needs to be raised, whether in Ladkana, Gujranwala. It should be a trickle-down effect from Karachi, from Lahore and other parts of the country. So that's my opinion. Thank you.
Thank you, sir. I may add one thing over here. So sorry. I'm announcing here that we will be developing a training center at Civil Hospital Karachi. A new building will be made, and just for the training purpose, surgical training for not only the people of Civil Hospital, but the whole city and the whole country. I think you're going to establish, and next time you come, you'll hear that.
Thank you, sir.
So that was quite an eye-opening and enlightening talk and a discussion. My next speaker is Professor Amjad Parvaiz Cheema. The professor is a colorectal surgeon with special interest in rectal cancer surgeries. He's the professor of surgery at University of Portsmouth, UK, and director of European Academy of Robotic Colorectal Surgery. The professor is also chief of colorectal surgery at Champalimaud Foundation, Lisbon, Portugal, and head of robotic program at Hamad General Hospital, Doha, Qatar. Professor, I welcome you here on stage.
अस्सलाम वालेकुम। बहुत शुक्रिया आपकी इनविटेशन का, और ये पहली दफ़ा नहीं है, मैं 2-3 दफ़ा पहले भी आ चुका हूँ। अमजद सराज साहब और उनकी टीम का, और all these people have been around. It's always a pleasure coming and speaking and training people. बहुत लंबा सा इंट्रोडक्शन की ज़रूरत नहीं है। मैं कोलोरेक्टल सर्जन हूँ, मेरा इंटरेस्ट मिनिमल इन्वेसिव सर्जरी में है, और मैं इंटरेस्टेड हूँ टीचिंग और ट्रेनिंग में. So what I'm going to present to you is based around perhaps my journey of about 20 odd years of sort of going around and teaching and training people. And what I probably would like to sort of highlight is that how training works. And I think this first little debate about getting people from outside, this is a different country, this is a different culture, I've been hearing it for the last 15 years. I come to this country every year, and everybody comes up with this. एक इंटरेस्टिंग चीज़ जो डॉक्टर साहब ने यहाँ से कही थी कि पहली चीज़ एक्नॉलेज करना है कि हमें सीखने की ज़रूरत है. तो मैं उर्दू में इसलिए बात कर रहा हूँ कि मेरा ख्याल है कि आप सब लोगों को उर्दू आती है, तो इसलिए मतलब मेरा ख्याल आसान हो जाएगा आपको समझने के लिए. कभी आपको लगा है कि इतने 500 साल पहले ऑटोमन्स वर द बिगेस्ट एम्पायर, नेवल एम्पायर्स, चाइनीज़ वर द बिगेस्ट नेवल एम्पायर्स, ठीक है. लेकिन वाई इट इज़ सो कि स्मॉल नेशंस लाइक Portugal, Spain, they discovered the far-off places, not Chinese dynasties, not Ottoman empires. हालांकि उनके पास नेवी भी थी. प्रॉब्लम ये था कि जब उनके पास कोई सजेशन लेके जाता था कि मे बी यू शुड इन्वेस्ट इन रिसोर्स डेवलपमेंट, नई जगह देखो, नया नॉलेज ऐड करो, तो उनका कॉन्टेक्स्ट ये होता था कि वी आर ऑटोमन्स, वट एवर इज़ आउट देयर वी नो दिस, हमें इसकी ज़रूरत नहीं है. सो दैट वाज द रीज़न कि जो लोग जिन्होंने फार ऑफ प्लेसेस डिस्कवर की और फार ऑफ प्लेसेस में जाके काम किया, दे स्टार्टेड विद फर्स्ट थिंग कि जब उनसे कोई सवाल पूछा जाता था, दे वुड ऑलवेज से, अगर उनको चीज़ नहीं आती थी, कि आई डोंट नो द आंसर, बट दे फॉलोड इट अप विद अ वेरी इंपॉर्टेंट सेंटेंस आफ्टरवर्ड एंड दे सेड बट आई वुड लाइक टू लर्न, शो इट टू मी. यहाँ से लोग पुलों के डिज़ाइन लेके गए जो अब 17th-18th सेंचुरीज़ में जो ब्रिटिश म्यूज़ियम में लगे हुए हैं, घरों के डिज़ाइन लेके गए, हाथ से बनी हुई तस्वीरें हैं. दिस इज़ द डेटा दे टुक फ्रॉम हेयर. तो हम सारे कहते तो ये हैं कि हमारी चेंज इधर से आएगी, हम यहाँ से सब कुछ चेंज करेंगे. अगर इतने सालों से हो नहीं रहा तो थोड़ी देर के लिए रिफ्लेक्ट करने में क्या हर्ज है कि प्रॉब्लम हम में है, बजाय इसके कहना कि बाहर से लोग आएंगे, बाहर से लोग इंपोर्ट होंगे, वो ये करेंगे. बाहर से लोग आके आपको गोल पोस्ट दिखा सकते हैं, चेंज यहाँ से आपको खुद करना है. अगर इतना ही सारी ऑनेस्टी है और हम सारे इंडिविजुअली इतने ही रिफ्लेक्ट करते हैं इस चीज़ पे कि हम सब इम्प्रूव करना चाहते हैं, तो वाई इज़ इट सो कि यहाँ पे अब तक ये चीज़ डेवलप क्यों नहीं हुई 15 सालों से. सो जस्ट सिर्फ थॉट फॉर रिफ्लेक्शन बिफोर आई स्टार्ट. चलो अब देखते हैं कि इफ़ वी कैन होपफुली शो यू समथिंग. Okay, so you have a picture? Okay. So I started my journey in this place. This is Portsmouth. This is south coast of England. 2006 I started here. I trained in Wessex region. I took a job here. इसलिए मैं आपको थोड़ी सी हिस्ट्री का कॉन्टेक्स्ट देना चाहता हूँ कि लोग अमूमन एंड रिजल्ट देखते हैं. मतलब लोग देखते हैं कि प्रोफेसर सो एंड सो यहाँ आ गए हैं. ही ऑलवेज हैड इट लाइक दिस. थिंग्स वर ऑलवेज लाइक दिस. ये एक प्रिविलेज जगह पे काम करते थे तो शायद इनके लिए बहुत आसान था. तो टू पुट थिंग्स इन कॉन्टेक्स्ट फॉर यू, दिस इज़ अ फैंटास्टिक प्लेस बाय द वे. आजकल मैं 2 वीक्स यहाँ गुजारता हूँ. दिस इज़ चैम्पैलिमॉड फाउंडेशन इन लिस्बन, विच मोस्ट ऑफ यू आर वेलकम टू कम. ट्रेनीज़ के लिए ओपन इन्विटेशन होता है. वी रन ट्रैवलिंग फेलोशिप्स फ्री ऑफ कॉस्ट एंड दिस फाउंडेशन पेज फॉर ट्रैवल्स एंड अकोमोडेशन एज वेल इफ़ दे गेट इन टू रिसर्च अटैचमेंट. और 2 वीक्स में यहाँ गुजारता हूँ. दिस इज़ हमद हॉस्पिटल इन दोहा. आई एम हेल्पिंग देम लर्न रोबोटिक्स एंड लेप्रोस्कोपी. सो टू गिव यू अ कॉन्टेक्स्ट, क्योंकि हम लोग सारे लेप्रोस्कोपिक सर्जन हैं, लेप्रोस्कोपिक करना चाहते हैं, बिकॉज दिस इज़ द सेक्सियस थिंग टू डू. दिस इज़ इफ़ यू नॉट डूइंग लेप्रोस्कोपी यू नॉट इन द ग्रुप. जनरली कॉन्सेप्ट ये है. ये कॉन्सेप्ट गलत है. लेप्रोस्कोपी इज़ जस्ट अ टूल, इट्स नॉट अ रिलीजन. रिलीजन रियली इज़ एनाटमी फॉर सर्जन्स. मुझे कुछ लोग अपने तस्वीरें भेजते हैं, सैम्पल्स स्पेसिमेंस की वीडियोस भेजते हैं, बिकॉज दे वांटेड टू सर्व शो दिस. ये इस मुल्क से भेजी हुई एक तस्वीर है. आप लोग इस तस्वीर को शायद देखे हों, आप लोग मीडिया पे शेयर करते हैं ग्रुप्स में. somebody sort of said कि we would really like your comment on this because this is the first laparoscopic APR we have done. Or if I look at it, I say it looks all right from outside, except perhaps the stroma is a bit lateral. Other than that, it looks okay. So I asked them to send me a picture of the specimen because I really wanted to look at the picture, because as a cancer surgeon, the focus really is on cure rather than just cosmesis alone. And most of you would agree that this is perhaps a suboptimal picture for a cancer oncology resected specimen. So for young people sitting in the audience, learn anatomy. Anatomy is the key. It's the key that would sort of dictate how good or bad you would become. And then use mere tool of minimally invasive surgery, be it laparoscopy or robotics, to achieve that anatomical dissections. It started by this guy. This is a French guy who did the first lap col in 1986 or 87. I think they started it. And you could see how things have changed in the last sort of 3 decades or so. This is 2006, my first week in Portsmouth as a colorectal consultant surgeon. ये जो स्टैक आप देख रहे हैं, इस पर ब्लू और वाइट पिक्चर नज़र आती थी. कलर स्टैक नहीं था ये, क्योंकि स्टैक ख़राब था, वुल्फ का स्टैक था. Nobody was interested in laparoscopy. और जब emergency people used to come and take this stack because they wanted to do lap appendices. So my fellow and registrar used to come 6 in the morning, try to get this stack so we could at least do lap case. तो उस वक्त भी हमारे कुछ सीनियर सर्जन थे जो मुझे कहते थे कि इतनी मुसीबत क्या है, तुम ओपन कर लो. ओपन भी तो कर रहे हैं. तो एक आइडिया तो ये था कि मैं उनकी बात मानता और ये सब कुछ करता. दूसरी चीज़ ये है कि if you genuinely believe कि इसका पेशेंट को फ़ायदा है, this is where the goal post is, where the goal post is going to move, then you sort of stick to it and then you sort of put an effort, you commit to it. This is Asha Senapati with her head behind. So my senior consultant colleague थी, she became president of ACP afterwards. मेरे पास कोई ट्रेनी नहीं है देखें इस पिक्चर में, because nobody was interested कि ये 6-7 घंटे लगाएंगे, पता नहीं ये क्या करेंगे. हालांकि उस वक्त 6-7 घंटे नहीं. I had sort of come in as a trained fellow after sort of doing the fellowship for Royal College of Surgeons. So this was a paper published in BJS from Robin Kennedy's and Yeovil group. I was an SR working with him at the time. And this created a lot of problem. BGS published it where he claimed, or we claimed, that our practice showed that over 90% of our elective colorectal cancers were done laparoscopically. With due respect to Professor Sub, not in a big teaching hospital in Bristol. This is Yeovil, the smallest trust in UK. 90%. And I worked with him for 3 years, so it was a true data. I know that he didn't make the figures up. We came to Portsmouth, 2005, I got appointed, end of 2005. This is an older slide to show how open surgery went down to under 10%. This is 300 plus colorectal cancer, all-comer practice, not choosing it. This is a data for 8 years or so. This has been published, by the way. This is not a sort of solitary slide that I'm showing you. Over 1,600 or nearly 1,600 cases, conversion rate of 3%, R0 resection rate of 98.7%, length of stay 4 days. Started with that single stack. 5 surgeons got trained. All my colleagues got trained. Some of them did this better than me. And I have shown it, no shame in admitting that some of my trainees did it better than me. एक जनरल कॉन्सेप्ट होता है कि ये हाई रिस्क मरीज है, बूढ़ी औरत है, इनको कार्डियक इश्यूज है, जल्दी से कोई ओपन ऑपरेशन कर दें. ये एक रिकरिंग थीम थी which I felt as a trainee. Everybody used to tell me, I can do the right hemi with a transference and it takes me about 45 minutes. This is publication Annals of Surgery from our group, where we looked at high-risk patient in 2 years' time that we worked in. High risk included people who were 80 and above, ASA grade 3 and above, who had preoperative chemoradiotherapy, T4 tumor, and BMI of over 30. This is a pretty high-risk group, really. And we compared lap and open surgery in our department, done by 2 very experienced open laparoscopic surgeons who were the senior consultants and 3 laparoscopists who were trained within the unit. So we showed that we had shorter hospital stay, better complication rate, reoperation rate, and readmission rate was slightly higher. So it shows that it is not only possible to safely do it, perhaps you improve the outcome if you imply minimally invasive surgery to this. And this has been shown in a number of trials. I don't need to sort of give you the run of classic colored trial, Korean trial, Spanish RCT done by Barcelona group, showing all this. So इसको लड़ने का कोई फ़ायदा नहीं है. ये मैं आपको यहाँ बैठे हुए लोगों को बता दूँ कि ये डिबेट है ही नहीं. कोई आपको ये कहे ना कि open surgery is trying to sort of stick to the relevance. Don't stick to this. See where the progress is. तो ये आना ही आना है. ये आज आए, कल आए, हफ्ते भर में आए, साल में आए, ये आएगा. ये revolution यहाँ पे भी आएगा. This is no exception. So, लोग सीखते हैं, people improve. This is classic trial. We were contributing data in Yeovil for this trial. ठीक है? Precondition क्या थी? आपने 20 केस किए हुए हैं, you are expert. You can contribute into this trial. And this trial showed that they had 34% conversion rate for rectal cancer, 25% CRM positivity rate in rectal cancer. ठीक है? This trial get quoted all around the world for the last 20-25 years. I've been going around the circuits and, people like to defend this trial. People who are against laparoscopy like to hang on to this trial because this is their relevance. People have, this group have published the long-term data now that even with 25% CRM positivity rate, there's no worse long-term outcome. Then this is color 2. 5-10 सालों में वही ग्रुप इंप्रूव हो गया जो 20 केसेस किए थे, अब उन्होंने 100 किए, 600-700 केसेस किए, फॉर एग्जांपल. Suddenly, the conversion rate goes down, CRM positivity got better. तो कुछ तो हुआ है ना. अगर वो पहला ट्रायल देख के कहते कि भाई ये हमारे बस का काम नहीं है, ये हमारा रेवोल्यूशन नहीं है, हमें इससे कोई लेना देना नहीं है. Progress doesn't work like this, I'm afraid. Look at this. This is Korean trial. Mid to low rectal cancer, T3 tumor, locally advanced, post-chemoradiotherapy. Look at the conversion rate, look at CRM positivity rate. Or मैंने वो स्लाइड थोड़ी काट दी है, बट यू कैन लुक एट दिस पेपर, इवन शोइंग बेटर सर्वाइवल आउटकम इन लेप्रोस्कोपिक आर्म. क्लू क्या है? क्लू ये है, जस्ट टू गिव यू एन आइडिया, ये ट्रेनिज के परस्पेक्टिव से मैं बता रहा हूँ अब. The clue really is to standardize your care. Operative technique is just one component of care. You know, previous speakers spoke about MDT concept. मेरे ख्याल में this is a crux that holds the cancer care back in this country. Radiology improve करें. We go on the basis of somebody sort of saying there is a thickening seen on rectosigmoid junction. Tumor आप finger पे feel कर रहे हैं, उनको rectosigmoid के ऊपर thickening नजर आ रही है. So this is a gap that we have to bridge, whether we like it or not. This is a consensus paper we published few years ago, trying to standardize laparoscopic TME. हमारे अपने outcome कहाँ हैं? This is a three-centered data, rectal cancer का. We showed, have a look at this. This is a 5-year overall survival rate of about 83%, disease-free survival, stage by stage, very respectable, with local recurrence rate of under 2%. This is all comers practice. Only 23% of the patient had chemoradiotherapy. ये नहीं है कि सबको रेडियोथेरेपी दे के फ्राई करके स्टेराइल कर लिया और उसके बाद ऑपरेट किया. And there is nothing magical about it. This two sort of slides you see, AP is my practice in Portsmouth. 3 different essential initials on the other side are my trainee at the time. One of them is sitting in this room. ये उनका combined data है जब वो consultant बने और अपने independent practice में गए. Exactly the same figure as they had it in the mother unit. So it is not only just, there is nothing special about it कि सिर्फ मैं कर सकता हूँ. There is no man in this. जो concept है ना training का, उसके लिए सबसे ज़्यादा important चीज़ है कि person who is really interested in teaching and training, he or she would be willing to progressively become irrelevant. Hang on to this thought. ये बड़ा मुश्किल है. हम सारे relevance चाहते हैं. हम चाहते हैं कि हमारी चुदराहट बनी रहे. मेरा ट्रेनिंग मुझसे अच्छा कर लेगा तो फिर मेरे आने का यहाँ क्या फ़ायदा है. ये प्रॉब्लम ये है सारा. जब आप जाओगे तो थोड़ी देर के लिए रिफ्लेक्ट करोगे तो तुम्हें काफ़ी सारे आंसर मिल जाएंगे. सो दिस इज़ द कॉन्सेप्ट. कॉन्सेप्ट क्या है कि आप जहाँ भी सर्जरी कीजिए, लेप्रोस्कोपिकली कीजिए, रोबोटिकली कीजिए, एशिया में करें, यूरोप में करें, अफ्रीका में करें, योर स्पेसिमेन शुड लुक कंसिस्टेंटली द सेम, यू नो. And this is what is a surrogate marker of our care. This is what your show off, जो लोग कहते हैं ना, show off वो नहीं है जो लोग करके दिखाते हैं. Show off ये है जो specimen निकलता है और आपको अपने आप को self critique करना है specimen की basis पे. Honestly, ये नहीं कहना कि operation ख़त्म हो गया, scar bar से नज़र नहीं आ रहे. This is what matters to patient. Robotics, same thing. Revolution came in 2013-14 in Europe. We were part of that. This is publication in Jameel Ahmed, who was our fellow at the time. He published this first 100 cases. SI system, जो यहाँ पे system है, इसको लोग कहते थे कि जी इससे स्प्लेनिक फ्रैक्चर मोबिलाइज करना बहुत मुश्किल है, पेशेंट फिक्स हो जाता है, इसमें व्यू का प्रॉब्लम है. People were doing hybrid techniques. They were doing all sorts of things. There is no need for it. So what did it show in our data? We showed that you have better urogenital nerve function score when you compared laparoscopy and robotics. We showed that it is possible to have better short-term outcome in obese and super obese patient. By the way, this has been shown in rollout trial, be it not like statistically significant, but they could see it. फिर ये एक पेपर कोलोरेक्टल डिजीज़ में हमने पब्लिश किया कि which showed that high risk group even done by robotic surgery have better outcome. तो बायोलॉजी तो चेंज नहीं ना हुई, एनाटमी चेंज नहीं हुई, टूल चेंज हो गया, और टूल चेंज होने से ये हुआ कि यू बिकम बिट मोर प्रोफिशेंट. So how can you reduce this? Let's get to the crux of it. आपको मैंने डेटा दिखा दिया where the goal post is. अच्छा, before I go, ये important चीज़ और है कि जनरली हमारा ये concept है, मैं with the permission of the chair people sitting here, मैं बहुत सालों से पाकिस्तान आता हूँ because I have extreme loyalty to this country. और मैं कोशिश करता हूँ कि मैं कंट्रीब्यूट कर सकूँ जिस तरह भी करूँ. जनरली लोग मुझे ये कहते थे कि हमारे पास रोटी खाने की वो जगह नहीं है, आप हमें केक खिलाना सिखा रहे हैं. जनरली ना जब नहीं करना होता ना, दिस इज़ द फ्रेज दे यूज़. और जब कुछ ठीक हो जाता है और कुछ लोग सीख जाते हैं तो फिर वो इकबाल साहब का एक शेर है कि ज़रा नम हो तो ये मट्टी बड़ी जरखेज़ है साकी. इस शेर को सुन सुन के मतलब मेरे कान पक गए हैं. जनरली दिस इज़ व्हाट पीपल हाइड बिहाइंड. ठीक है. How do you reduce the learning curve? Important चीज़ is कि you should have consistent and standardized technique to show you. My operation should look predictably the same every day of the week. Then my trainees can appreciate what normal look like. Then you would be able to appreciate what abnormal is. ठीक है, ये important है. दूसरा ये है कि I should have a technique which everybody else could reproduce. There is no point me dying with this, that I'm so special that nobody else could do it. Then perhaps it is not a technique that is applicable to general masses. And if it looks good, it usually works. And the other thing I learned from Amjad Siraj Saab कि कराची के लोग थोड़े intellectually improved हैं as compared to the rest of the Pakistan. So let's put you to the test. What do you think is this place? It could be अगर इंग्लैंड कुछ लोग आए हों कराची तो नहीं है ये What? Sir Parker? Okay, fair enough. What do you think is this? ये कराची नहीं है ये तो मुझे पता है What do you think is this? Russia, Moscow, you know? Why do you recognize this particular thing? The truth is, this all three pictures that I have shown you are within 3-kilometer radius in central Moscow. First picture I took in 2011 on my way from the airport. First time I went to Russia. तो मुझे बड़ा glooming दिन था मैंने तस्वीर खींच ली. Rest of the time are from the internet. फिर मैंने Google पे देखा तो ये 3 किलोमीटर के radius में है. Why do you recognize this? Because this is the pattern you have seen. This is the picture, it is in your memory bank. Or that's why I go on about having a consistent, standardized pattern recognition approach so people can appreciate what it should look like. So, आपको मैं अब 3 example दूंगा training program की in 3 different parts of the world to put across the message that how it is possible to generalize it. And it is not only for privileged few that they are able to do this. This is UK, which is my second home. और डॉक्टर साहब ने जो मुझसे पहले प्रेजेंट कर रहे थे he sort of shared some of this. This is a national training program, resource failed country, over 12 million indirect and direct cost in investing into training their people. उनको भी ज़रूरत थी सीखने की, even resources होने के बावजूद, इतना सब कुछ होने के बावजूद. So how they started like this. You don't go around and train people in Larkana, Sakhar, Gujarat, Gujranwala, Attak. You put regional centers and make them to a level where they can train the districts. That's the key, in a way. And this is how they started. So they had a steering group, then they picked up national training centers. Generally, there were about 10 or 11 dotted around England, and then people were asked to register into the program. Putting any effort into any training program is to be underpinned by competence assessments objectively. It can never go on कि अमजद साज साहब मेरे दोस्त हैं, मैंने 2 केसेस करवा दिए और उसके बाद कहा कि मेरा ख्याल है आप ठीक हैं. मतलब जरा मैं उनको ये नहीं कह सकता कि वो चीज़ improve नहीं कर पा रहे. Important thing है you must have objectivity attached to your assessment. This is how it went. The people were assessed as they were trained with a global assessment score sheet. People were scored on each module of the operation from 0 to 6, and that produced a data which was looked up nationally. You can look at it on an average. It took 22 cases for people to have a flattening of the curve where they could do procedures safely. So you got to put science behind it. You got to put objectivity behind it. When they finished their X number of cases under supervision, they were asked to submit 2 unedited DVDs which were assessed by central committee blindly before they were able to deem competent or incompetent or resubmit for that matter. This is the data coming out of the program. This is volume, training center volumes, and so forth. And this was the impact at the time when this lab course sort of kicked off. Within 4-5 years, 45% of all colon and rectal cancer in England were done laparoscopically. The figure stands now around 68-70% in UK. So it does have implication. It is possible to reproduce this. It is possible to propagate this. अच्छा अब वो इंग्लैंड है मतलब अल्लाह आलम क्या खबरें हमें दिखा रहे हैं स्लाइड दिखा रहे हैं मानने वाली बात है भी कि नहीं. दिस इज़ पाकिस्तान, दिस इज़ हेयर. इसी मुल्क में रहते हुए कुछ लोग वो सारी चीज़ें जो हमने टॉक के शुरू में की थी, दे हैव अ डिफरेंट माइंड सेट. दे आर प्रिपेयर्ड टू से यस आई डोंट नो टीच मी. This is one such group in Lahore. ये शौकत खानम का डेटा है, ये मेरा डेटा नहीं है, ये उनके लोगों का डेटा है जिन्होंने मुझसे काम सीखा और मुझसे अच्छा रिजल्ट प्रोड्यूस किया. I think one of them is sitting here somewhere. This is their data when they change from open surgical technique to laparoscopy in right colon cancer. They were able to show not only better short-term outcome, जिसके ऊपर सारे लोग emphasize करते हैं, it showed better survival function, stage by stage. Stage 3 had a significantly improved survival. ये नहीं है कि वो अच्छे surgeon एकदम बन गए. They started selecting well, they started learning the anatomy, they had less morbidity in laparoscopic arm, which means that the stage 3 patient were able to get to chemo in time, and that have an influence in improving the survival as well. This has happened in this country. ये कोई बाहर की बात नहीं मैं आपको कर रहा. इन लोगों का आप डेटा देखिए. वजह सिर्फ ये है कि they are willing to say कि हमें कुछ सिखाए आके और हम उसको reproduce करेंगे. वो अपने लोगों को आगे से सिखाते हैं. One such unit is trying to do this here in Karachi, and I'm sure there are other units as well, Peshawar, capital and so forth. This is Serbia. किसी ने नाम सुना हुआ इस मुल्क का? Good. One of the guys saw me in Moscow and he came to me and said, okay, I've just seen you operate and you come from England or whatever, come to my country, we would like to learn this from you. तो मुझे देखना पड़ा कि सर्बिया है का. मेरे ज़हन में यही था वो जो बैल्कन वॉर थी. So I went to the place. सुबह हॉस्पिटल जाना था तो मैंने कहा कि गाड़ी आ गई है. तो उन्होंने कहा हमारे पास तो यही है इस शहर में. This is a Penchivo. This is outside Belgrade. And I want you to sort of remember this and put this into context. When people have a will to do something, when they are prepared to accept that I need to learn how change happens. हमने इस ग्रुप के साथ 6 दफ़ा मैं गया एक साल में. हम सामान भी बाजुकात लेके जाते थे. Or we put them through this, we bring them to the level where they independently did 100 cases and they presented in the National Congress. 100 laparoscopic resection, small district hospital in Penchivo. The health minister got their attention and said कि ये तुम एक छोटे से अस्पताल में कैसे कर रहे हो, हम तो teaching hospital ये वो. He said कि I've got a friend in London. उनका ख्याल इंग्लैंड में सिर्फ एक ही जगह है लंदन. तो वहाँ से वो आता है और हमें सिखाता है. So he asked me to come and spoke to me and said, can you not reproduce this in the country? So they set up this LabServe program, which is the same replica of LabCo. कि आप 8 training center develop करें, 16 surgeon. उनको उसी process से गुजारें, stringently, objectively, and then ask those 8 centers to train the districts. It required commitment, it required series of workshop, it requires you visiting a lot, people are putting up cases, making sure that they work. उसमें और बहुत से लोगों ने मेरी हेल्प की. अकेला मेरा काम नहीं है. मेरे को this is Jan Kuzu who came here and did this. आखिर में क्या हुआ कि 8 से शुरू हुआ, 40 contributed now. This is their publication. अब अगर आप देखना चाहते हैं, over 1600 cases done in 2 years by the country, which had nearly 0%. अब sporadic 2-4 लोग करते थे. ये उनके outcome है. Just as good as LabCo. इस पे इन्वेस्टमेंट क्या है इस प्रोग्राम पे पता है आपको? इस इन्वेस्टमेंट इसमें कुछ डिनर्स हैं जो उन्होंने मुझे लेके गए. मेरा एयर फेयर है और एक कमरा सुलाने के लिए. बिकॉज दे वर कीन टू डू दिस. यू नो इट डिडंट रिक्वायर 12 million pound एज यूके इन्वेस्टेड इनटू देयर प्रोग्राम. क्योंकि नेशनली वो लोग चाहते थे कि अब इम्प्रूव हों. नाउ दे आर द सेंट्रल कंट्री इन Balkan ट्राइंग टू ट्रेन पीपल इन Croatia, Poland and Bosnia. Just finish off by showing this with robotics. It is not only laparoscopy, it is robotics which holds the same ethos. This is a group in Poole, Tehseen Qureshi, and then in Lisbon. When 3 surgeons were put through the test, same way when we looked at their Kusum curve score of gaining competence, and we were able to demonstrate this. 3 surgeons did 10 supervised cases under supervision, then went on to become independent, did 50 cases, similar outcome. Go on to Europe, not only a small centers. This is a European program run for robotic colorectal surgical training. अब इनको ज़रूरत क्या है सीखने की? इनको तो सब कुछ आता है. They are the world leaders, but they are willing to say that we need to learn. And that's what I keep going back, and I'm keep emphasizing this. The deal breaker is this mindset that I need to improve. और दूसरी एक चीज़ याद रखिए कि हम सब बहुत जल्दी बार सेट कर देते हैं, मैं बार सेट कर देता हूँ इस पर कि बस तुम यही कर सकते हो, यही स्टैंडर्ड है, वो वहाँ कहीं होता है, वो हमारे वाला नहीं है. I have absolutely no right to put a bar on somebody's brilliance and competence. I have had my chance, I've done a race, you know. उसका he or she has got their own run to do. और उनको इस छोटे mindset में कभी ना रखें. Tell them where the brilliance is. यहाँ से लोग जाते हैं, बाहर जाके इतना excel करते हैं, उनको वहाँ पर लग जाते हैं, ऐसा नहीं है. Because they are given a fair run. और ये याद रखिए जब आप ट्रेनिंग कर रहे हैं, goalpost is not around you. Goalpost is where the brilliance is. And this is what you need to see. This is the published data from that program. 26 centers, over 1,000 robotic colorectal cases. अब ये slide बहुत ज़्यादा है. Bottom line was this, कि when they were trained, they were able to reproduce the same outcome as the proctors and the trainers who trained them. I'm sure that you all want to look at this slide now. So MII surgery, in my belief, there is no debate. You know, there is no such debate as कि laparoscopy पता नहीं आएगी नहीं आएगी. It is here and it's going to stay. Whether I like it or not, it is possible to produce similar clinical outcome regardless of trainees' level if you have a consistent common denominator of how you train them and who's training them and which program is training them. Structured training in laparoscopy makes the learning curve shorter. Standardization of operative technique is a key. अब सब लोगों का emphasis robot पे है. I'll finish off by just saying this. Fashion है इस मुल्क में, हर अस्पताल में वो एक CMR robot है, वो लगाने की कोशिश कर रहे हैं. और ये bottom line क्या है बच्चे? Bottom line देखें ये है, anatomy is the same in Homo sapien and it hasn't changed in the last 250,000 years or so. अब ये जल्दी में change होनी भी नहीं. कैंसर का biology एक ही तरह है, tool different है. अब ये expect करना कि robot is going to come and it's going to do Bill Heal's operation for rectal cancer, it is like a felony really in a way कि ये एक fallacy है कि मैं कहूँगा ये robot वो operation करेगा. Robot surgery would demonstrate marginal gains, and to improve those marginal gains you have to really practice hard with high volume. अमजद साहब बहुत शुक्रिया आपका, आपकी टीम का, आप लोगों का शुक्रिया इतनी देर मेरी बात सुनने का. Thank you very much for having me.
Thank you so much. Can we have questions? 2 questions from the audience first. Anyone?
Thank you, Professor Cheema. You have enlightened us and showed us the way how to go around things. One thing which I feel we lack is accountability. I think if we are given a task and I'm not asked what results I have produced, then we are going to falter. And that's what needs to be introduced in our system. That should be accountability. What I was asked to do, I should accomplish it. And if I fail, what I have failed, I should be asked about it. I think that's where we lack.
No, I think you've hit it on the head. When as a young trainee, I was asked that publish or perish. You know, history always remember people in the way it's been written, because most likely they have written it. That's the key. राइट अगर आप अपना डेटा नहीं रखेंगे, अपना डेटा पब्लिश नहीं करेंगे, गेम आपको देखना है कि रूल्स ऑफ एंगेजमेंट क्या हैं. रूल्स ऑफ एंगेजमेंट ये है अपने लेवल पे सेल्फ क्रिटिक, ईमानदारी अपने से कि मैं जो करता हूँ इज़ इट वर्थ फाइल गेटिंग आउट ऑफ द बेड इन द मॉर्निंग. अगर नहीं है तो क्वाइटली टेक अ साइड ट्रैक, ठीक है, ये बस का बात नहीं. लेकिन अगर इट गिव्स यू अ रीज़न टू गेट आउट ऑफ द बेड इन द मॉर्निंग, देन यू मस्ट हैव अ डेटा टू बैक इट. सब लोग एक जनरल परसेप्शन क्यों है वेस्टर्न हेमिस्फेयर में या जो डिफरेंट पब्लिश जर्नल्स हैं पीयर रिव्यू में कि यहाँ से वो डेटा लेते हुए घबराते हैं क्योंकि दे डोंट नो कि कितना ऑथेंटिक डेटा है. ये नहीं है कि लोग यहाँ ईमानदार नहीं. देयर आर सम फैंटास्टिक पीपल हु वर्क्स इन दिस कंट्री, दे प्रोड्यूस एक्सलेंट आउटकम्स. लेकिन फॉल्टर यही है कि डेटा नहीं रखेंगे, अकाउंटेबिलिटी नहीं है, ऑडिट का कॉन्सेप्ट नहीं है, एमडीटी का कॉन्सेप्ट नहीं. एमडीटी का मतलब ये नहीं है कि वो आपको मुझे बताती है कि कैंसर का ऑपरेशन कैसे करना है. That is a gatekeeping mechanism to figure out कि अगर मेरे margin positivity rate 25% आ रहे हैं, they will stop me as a surgeon. ये बहुत ज़रूरी है. और इसके लिए मतलब if you ask me what is one magic pill that needed to improve cancer care in this country, it is the concept of MDT. It's the concept of training allied specialty around the surgeons.
I think you are so right about it. Once I did a locum in England. I was doing a locum consultant, and I was doing a locum of a person. He was a consultant surgeon, but he was sent for retraining because he wasn't getting the yield that was expected.
Yes.
And that's what I meant by accountability. I think we should be giving what we are supposed to give.
Thank you, Professor. Thank you for such a nice talk.
Thank you very much for putting up with me.
So, passion to learn and enthusiasm to teach, that's the bottom line. My next speaker would be Professor Kamrul Afeen. The professor is a well-reputed and an experienced gastroenterologist, and at present is the faculty GI at Ziauddin University Hospital. Sir, please.
Assalamu alaikum. Good morning, everybody. Professor Cheema has done a great job in presenting. I'll bring you to the basics of colonoscopy and its. Yeah. Which one is it? So, topic of my talk, this slide is being opened now. The topic of my talk is colonoscopy, role of colonoscopy in the screening and management of colorectal cancer. So, it's not loaded. Change कैसे करें? Okay. Fine, sorry about the mess. Now going to start with, we all know, this is just a refresher for us, that's who is at risk. We're going to the basics of colonoscopy and risk involved in it, and then followed by a few endoscopic techniques of EMR and ESD. So we all know that most of the colorectal cancers are sporadic. Generally, it's causing about 70% of them. 10 to 30% would be familial cases of familial risk. Factors about 10 to 30%, and rest of them are Lynch syndrome, familial adenomatous polyposis, or hematomatous polyposis syndrome. Now, as we can see, the hereditary risk factors are positive family history, hereditary colorectal cancer. Other risk factors include long-term inflammatory bowel disease, type 2 diabetes, male gender, etc., and the risk factors which can be improved. And the risk factors which can be improved. Sorry. Here is these are the factors: smoking, processed meat. These are the modifiable risk factors which can be improved if we do a lot of exercise, physical activity, whole grains, etc. How do we screen? Whom should we screen and how should we screen? A screening of colorectal cancer is no published data available as standards or guidelines for low risk group. The average risk group should be with every society of, if you can see the American Society, Cancer Society, American College of Gastroenterologists, and American College of Oncology. They all suggest that the Average population, average risk population should be screened after 45 or 50 years of age. With fecal occult blood testing, fecal immunochemical test, along with flexible sigmoidoscopy or FOB or FIT with flexible sigmoidoscopy every 5 years, double contrast barium enema every 5 years, or colonoscopy every 10 years. Now, these are the stool-based tests are fecal occult blood, FIT plus DNA, and the direct visualization test would be colonoscopy, CT chromography, colonography, flexible sigmoidoscopy, or flexible sigmoidoscopy along with FIT. Now, the role of colonoscopy, this is the topic of my talk today, is role of colonoscopy in colorectal disease. It's a fundamental role in the prevention and management of colorectal cancer patients. Useful for both the diagnosis and treatment of early colorectal cancer and its precursors, i.e. polyps. It gives a high quality results, reduction in the incidence of mortality of the disease. Now, while we are doing colonoscopy, making a diagnosis through colonoscope, careful lesion characterization is the hallmark, which includes location of the lesion, size, macroscopic type, which we are going to discuss in a little while, color of the lesion, surface pit pattern of the lesion, which is classified in Kudo classification, etc. So this is the macroscopic classification, which is the Paris classification, is accepted worldwide. And as you can see, it describes the shape of the neoplastic lesion. It is categorized in two categories, polypoid and non-polypoid. Polypoid lesion would be either pedunculated or sessile. Non-polypoid, as you can see again, is pedunculated sessile, and they are classified into 2A, 2B, 2C. They are all either more or less truly flat lesions. There's slight elevation. Height of the lesion will not exceed 2.5 millimeters. Either they are truly flat or slightly depressed, and 3 is excavated, and mixed type will contain all of them. So this is the diagrammatic representation. As you can see, these are the protruded lesion on the left hand side. Either one P is pedunculated, one SP is subpedunculated, and the other one is sessile but elevated. Here are the flat elevated nodules, lesions. They are 2A, 2C, slightly excavated and depressed in the center, and the third one is 2A plus 1S is flat elevated lesion, a broad-based nodule. And then the flat lesion we are talking about is flat in the mucosa, is completely flat, but they look abnormal. Either they may be central depression, mucosal depression, or they may be excavated. Now, the Kudo pit pattern classification is another type of classification which we see endoscopically and on narrowband imaging. As you can see, that the two types on the top, type 1 and type 2, they are round pit normal or asteroid pattern. They are non-neoplastic, while the rest of them with tubular or round, dendritic pattern, irregular arrangements, etc. They all have neoplastic component in it. Now, capillary pattern is extremely important, as it gives correlates highly with the final histopathology. Therefore, the different systems have been established by different companies. Say the Sano system classifies lesions on the basis of their mucosal vasculature, microvasculature, with optical enhancement, with narrowband imaging on Olympus, eye scan imaging processing on Pentax, and fusion on intelligent chromoendoscopy. This classification system is an alternative means of classifying the risk of submucosal invasion. It correlates quite beautifully with final histopathology, is useful for differentiating hyperplastic lesions. Capillary pattern 1 is adenomatous, is hyperplastic, and 2, 3, and 3B are neoplastic with adenomas. This is the diagrammatic representation. As you can see, the various types in it on narrowband imaging. And now in indications and limitation of endoscopic resection in colorectal cancer. Cancer confined to the mucosa and superficial submucosal layers can be resected via flexible endoscopes. Early colon cancer defined as those confined to the mucosa or submucosa that does not invade the muscularis propria. It is important for us to know, we'll come up to that in a little while, that what are the real contraindications in doing EMR or ESD. Intramucosal cancer is virtually never associated with lymph node metastasis and can be resected via colonoscopy. Once the submucosal layer is invaded, metastasized lymph node involvement is reported in 6 to 13%. Now, how do we treat? These are the various ways of treating colorectal lesions via colonoscope. Snare polypectomy, endoscopic mucosal dissection, and endoscopic submucosal dissection. A snare polypectomy is pretty simple. Indications are sessile polyps of not more than 2 centimeters in size should be snared. Adverse effect, we all know, bleeding, perforation, local peritonitis, and routine polypectomy should generally be avoided when an invasive lesion is suspected. There are things which we have to remember. If you are suspecting by any means that the lesion is advanced and it is invading the submucosal after the muscularis propria or deeper layers, then you should not attempt EMR or ESD. If there is a non-lifting sign while doing injecting, I'll come up to that in a little while. We try to inject submucosally to elevate the submucosa to bring a cushion for the endoscopist to grab the lesion via the snare. And if that is not happening, it's a non-lifting sign, we should not attempt that. It tends to support that the lesion is either has fibrosis, significant fibrosis, or has invaded deeply. So these are the routine polypectomy should be generally avoided when the invasive lesion is suspected. Now it is pretty simple snare polypectomy. As you can see, you can grab the stalk of it's a pedunculated polyp. You grab the stalk with the snare and use electrocautery, and you can see the result there at the right end. And in flatter lesions, you inject with solutions. We are going to come up in a little while what kind of solutions we use in it. And then you elevate the lesion, separating the muscularis propria and deeper layers, and grabbing the polyp or the lesion, and then again apply the electrocautery and do it. The result is at the right side. Now, indications are that lesions confined to the mucosa or submucosa of the colon in which the risk of lymph node involvement is negligible. How do we, generally it is done using various techniques, but you need to ensure that the lymph node involvement is next to none. Lesions that are 2 centimeters or smaller in size can often be removed en bloc, whereas larger lesions may require endoscopic piecemeal resection. The technique of the procedure is that you see here is on the left hand side, needle injection is used, water immersion is also used, a cushion is created, and then you can see either you do hot snare, cold snare, EMR, or underwater EMR. All of them are being used, and in literature they say that hot EMR has a slightly increased risk of adverse events in terms of complications. But cold snare, underwater EMR, all of them would have similar results and the resected specimen can be removed en bloc. The technique combines snare polypectomy with additional submucosal fluid injection. Solution is injected into the submucosal sclerotherapy needle to raise the lesion for easier removal and to provide cushion to protect the deeper layers. After lifting and bulging, the lesion is captured in a snare removed via cauterization. A safety margin of 1 to 2 millimeters of normal mucosa should be included. Prophylactic closure of the defect with endoclips may prevent delayed bleeding and theoretically delayed perforation due to cautery effect. Now, solutions which we use in this kind of EMR technique, either we use commonly used normal saline, short-lived. We generally combine saline along with diluted epinephrine to minimize the risk of intraprocedural bleeding. But hydroxypropyl methylcellulose, glycerol, starch, volume, expanders, epinephrine as I discussed, diluted dye, indigo carmine or Indian ink can all be used, and which basically delineates the extent of submucosal cushion and can be used to confirm whether the resection is in the right, correct plane. Now, as you can see, it's a diagrammatic representation again. You can see the large sessile polyp, elevation polyp by fusion, and then resection using a snare, use electrocautery, and the result is in C. Polyp was removed. This is the result, what it happens before and after. EMR should be attempted only if complete resection of the neoplastic lesion is expected. Success rate of AMR is 90 to 100%. Complications are bleeding, 10% of all cases, and perforation, which is 1 to 2%. If perforation happens, you suspect, you hold on to the patient. If there is a possible peritonitis, we can suspect clinically. Surgical referral should be done immediately after resuscitation. Residual recurrence, short term is 2 to 6 months, is 0 to 55%. Late recurrence is after 12 months, less common, and less than 5% in one study. Surveillance should be first follow-up colonoscopy is performed 2 to 6 months after the procedure with both endoscopic and pathologic evaluation to ensure complete removal. Now, this is another technique which is a little bit more advanced than EMR, and the principle is practically the same. It's known as endoscopic submucosal dissection. It is quite widely used in upper GI pathologies, mostly in Barrett's and squamous cell carcinoma and adenocarcinoma of the esophagus, but it's extensively used in the lower GI as well. Now, indications are early invasive lesion confined to the mucosa or superficial submucosa measuring greater than 2 centimeters in diameter, lesions with shallow submucosal invasion, and lesions measuring less than 2 centimeters but containing significant submucosal fibrosis precluding EMR. As we discussed before as well, that it's a non-lifting sign when you inject it and try to lift the lesion, and if it is not lifting, it's a non-lifting sign, and it tends to support that the patient has fibrosis underneath the lesion, or it has already invaded the deeper layers, so it should not be attempted. So contraindications are deep mucosal invasion, as we just discussed, and the procedure technique is like this, and you mark the lesion along with indigo carmine, then you inject the special fluid as we discussed before under the tumor, cut the area with a needle knife, and then shave off the tumor, remove the tumor, and stitch it with endoclips. So to describe the procedure, as you can see, determination of the tumor borders by chromoendoscopy with indigo carmine spraying using narrowband imaging. A submucosal injection is administered in the area, needs to be incised to create a fluid cushion. Then incision was made, and after repeated submucosal injection, it is essential to maintain a submucosal dissection plane through the submucosal layer while avoiding the injury to the muscular muscularis propria. When thick vessels are observed, a prophylactic homeostasis maneuver can be done with using organ photocoagulation or coagulation forceps with soft coagulation. This is what happens pre and post procedure, and if there is a defect, you can always use endoclips to avoid the perforation. Complications are bleeding, again the same as EMR, but it's an extensive procedure, so you would expect a little bit more in it. So bleeding can happen, develops after the completion of procedure and occurs due to a rupture of exposed vessels, can be coagulated with APC. If the vessels are large, clipping is useful maneuver. Perforation can happen. Surgery is indicated if you suspect perforation and peritonitis. Follow-up is based on the status of the margins. If the margins are negative, recurrence rates are very low and surveillance can be deferred for at least 1 year. If the margins are positive, then the follow-up can be performed 3 to 6 months. And thank you very much for your kind patience. Thank you.
Thank you, sir. Can we have some questions? Quick one. From the audience, a quick round of questions.
I think we should have some questions from the audience. They have been quiet up to now.
Thank you.
What percentage of your practice has been medical?
What? Tell me again.
What is the percentage in your practice that endomucosal resections being performed as a GI physician?
Yeah. In Pakistan, we do not see those many polyps, and it's a big exercise to convince them to go through these procedures as a part of complications. But certainly, about 25 to 45 roughly in my practice that I've seen and I've done EMRs.
Thank you.
Anyone else?
So I would like to ask a question. A very informative talk, very interesting talk to listen to. Have you considered screening colonoscopy in Pakistani population, or it can be a national program for colorectal cancer? What are your thoughts about it? And obviously I know there are drawbacks or it's difficult to implement nationwide, but can it be considered from a small projects like a city, model cities, and then starting gradually progressing and implementing the whole country? What are your thoughts about it?
Thank you. It's a good question, and it's always been discussed along our colleagues. Basically, as Dr. Cheema has been suggesting all along, that we should have a will to start. So far, we have been, my personal experience that I've been working in a private setup, and it's difficult to establish. But certainly, lately I've been involved in the government setup as well. There has to be a kind of screening program. We need to outline, chalk out what group of patients, as we have the guidelines, we don't have a problem. The average population risk patients should be screened. There should be teamwork, starting from scratch, counseling them, booking them for routine colonoscopies, and definitely compiling the data again to establish that what kind of, that's the only way forward, I believe.
One thing that, yes, we were discussing the same thing, that in Pakistan, digital rectal examination is a screening tool, as we see. Second thing that I would say, that the endoscopy, upper GI, lower GI endoscopy is not only the domain of the gastroenterologist, it's also for the surgeon. And for the modern surgeon, we have got the modular theaters, we have got the combined things, and it is a syllabus, and part of the training of the surgeon, they should know colonoscopy and the gastroscopy. And before starting the procedures, they should do themselves the colonoscopy and the gastroscopy. And don't think this, I'm just discussing that from the cognitive point of view, it was a good lecture, but we have to implement, we have to start the implementation research, and who will start? The stakeholders. And who are the stakeholders? They are not doctors, they are outside. So it is not the doctors who determine the things, it is the things outside the doctors who determine the morbidity and mortality.
And Dr. Saab was asking me the question that yes, that answers his question. Actually, as a group of doctors, we can always chalk out the plan how to make plans to establish or start the colorectal screening program. But we need a lot of support from outside, I believe.
Thank you, Professor, for a very informative
When you are
talk.
doing EMR and there's a chance of perforation, remember me, I'll be around you.
Okay, thank you.
Just one question before you leave. We are seeing colorectal cancers in young patients in teens and 20s. And they don't have polyposis, they are just incidental, they don't have family history. So have you looked into it? What is the etiology of colorectal cancer in this young age group?
I believe genetics testing should be one of those tools which unfortunately we don't have. In young population, we are certainly, you're absolutely right, as Dr. Saab was presenting as well, that we are seeing a lot more in younger population than the older population. I don't think it could be related to many things, including dietary, genetic predisposition. We have no answer to that, to be honest with you, why it's happening in the younger population. The only paradigm shift is the use of junk food and dietary habits have gone worse. Other than that, we need to sit down and we need to establish the means and ways why it's happening.
I think a lot of research is needed.
A lot of research is required to answer that question.
So we have one.
There's a question from the audience.
My name is Dr. Shuja Ahmed. I'm actually practicing surgical oncologist in America. I just happened to be here for vacations, so I thought I'll attend the conference. I had two questions for you, Doctor. One was, as far as screening goes, you mentioned a whole list, and barium enema was one of them. Is there a role now, because in States we're moving away from barium enemas and doing CT colonography instead. So is there a role in Pakistan for that instead of the barium enema, because it seems to be more accurate? And the other question was about the EMR. You said the recurrence rate was, you quoted a wide range from 0 to 55%. So the 55% I would think is on the higher side of recurrence. Yeah. So is that the cause positive margins, or is it just local recurrence? So if that is local recurrence is high even with negative margins, do you have a protocol for follow-up colonoscopy within the next year or 2 years, or how do you sort of follow up on those?
Yeah,
thank you.
I'll answer your second question first. Yeah, the rate of recurrence is 0 to 55%, and the rate of recurrence is not, it's the leftover margins, I believe, and that can be handled easily with the help of repeat procedure within 3 to 6 months, and try to ensure that you clean up the margins, endoscopically as well as histologically, after taking biopsies. Reason of recurrence is obviously the leftover tumor cells. It's not the recurrence within the lesion in itself. Number two, what was your first question? Can you? I think CT colonography and barium enema. Obviously, they are still in the guidelines. If they are reserved for those patients who do not want to have colonoscopy for X, Y, Z reasons, or they are prohibited because of their severe illnesses. In those patients, sigmoidoscopy, barium enema double contrast variable studies, or stool-based tests are the starting screening test. If somebody is fit for colonoscopy, and you can, in Pakistan, if you can convince them to go through the procedure, the colonoscopy is the first choice.
Double contrast enema has got a great role in the diagnosis of the diverticulosis of the colon, where you miss by the colonoscopy and you cannot see the deep pouches where double contrast enema has got a great role. So still we cannot rule out that double contrast enema should be obsolete.
No, we are talking in terms of colorectal cancer and polyps. We are not talking about diverticular disease at all. I totally agree that obviously the double contrast study would delineate more clearly the outpouchings of diverticular disease, but it may not pick up the lesions, tumors, polyps. If it does, then still you need to go back in to do colonoscopy or sigmoidoscopy to obtain biopsies.
Excuse me. Yeah, there's one more. Can we have the mic for the gentleman?
Ji. Outpatient department with the bleeding PR. So I want to say you that every patient we send send for the colonoscopy, or we assess when there is a sign of the tumor, then refer to the colonoscopy.
Dr. Saab, the patient has a bleeding PR. You need to take a proper history, and you need to do a digital rectal examination. You need to suspect. Obviously, as per guidelines, if somebody is, as we discussed here, and the average high-risk population should be screened. If somebody is falling around 50 plus years of age and presenting with bleeding PR and some constitutional symptoms which might be pointed towards malignancy or polyp, then you must refer them for colonoscopy. But we should not, forget the basic principles of medicine, like examining the patient, taking a proper history, examining the patient. History might tell you that the patient has a family history of colorectal cancer, and that patient should be referred straight away, that they fall in high risk. So history taking, examination, and if you are suspecting that the patient should be referred for colonoscopy, should be.
Thank you.
But
many times I have seen that my juniors examine and they suspect the hemorrhoids. They inject or ligate the hemorrhoid, but repeatedly patients came to us, and when I see, I have myself examined that he has the tumor.
Yeah, I mean, if somebody, to be straightforward to you, if somebody is coming with bleeding PR and you have done DRE, you have done proctoscopy, you have seen hemorrhoids, you have injected, you must establish there is a reason for hemorrhoid. You must look for flexible sigmoidoscopy at least. Okay. And if you are suspecting, as I said earlier, if you are suspecting that this might be colorectal cancer, should be immediately referred for colonoscopy.
Thank you, Professor. Thank you.
Hello. Thank you very much. You have been very kind, and we learned a lot from you.
So that was a very informative talk by Professor Qamar. And I agree with Dr. Razak that surgeons should learn how to do scopes, and quite well. So my next speaker would be Dr. On Jamal, who is a surgical oncologist and advanced laparoscopic surgeon with 30 national and international publications in index journals, currently working as assistant professor of surgery at Amir Deen Hospital. Sir.
I'll try to. Assalamu alaikum everyone, good morning. So I feel myself honored to be presenting my data over here and in the presence of my teachers like Professor Amjad and Dr. Irfan. Can I have the slides please? So I was trained at Shaukat Khana Memorial Cancer Hospital, and I am accompanied by my senior registrar over here, who is Dr. Azhar. So these are the three places I practiced. I practiced, trained at Shaukat Khana, and now I practice at Lahore General Hospital and Evercare Hospital. So I have no disclosures, and the objective, briefly I'll go through the objectives of my talk, is a brief intro on distal rectal cancers, which I'm sure all of you know better than I do, and the role of APR in the management of distal rectal cancers, the APR versus conventional APR versus accelerator approach, and my technique, which I learned from my were the seniors and specimens, resection cavities, modes of reconstructions, and the data of 103 patients we have dealt with, and the issues with ELAP. So introduction, briefly, this is the third most common cancer. And again, the management of distal rectal cancers is complex. We all deal with rectal cancers, every one of us does, but the management of proximal and mid-rectal cancers is entirely different as compared to the distal rectal cancers. And believe me, distal rectal cancer, despite adequate resections, carry a sort of poor prognosis. So, needs multimodality treatment, MDT approach, and laparoscopic and robotic management is the standard of care. Clearly, I was being trained in a laparoscopic environment, and I clearly say, in this era, there is no role of open surgery. Gone are the days when we were operating open. So I know we all have logistic problems, but if we are trained proper, and if we have, all the logistics, जब मैं पहली दफ़ा COLOCON पे 2019 में आया था, तो I was practicing at Shaukat Khana. And at that time, probably, going to a government setup and starting all these facilities was a dream. But believe me, everything happened. We arranged all the logistics, and I'll show you the work which I did after Shaukat Khana. So, distal rectal cancer, the upper and, mid-rectum, we all know is being enveloped by the mesorectum. But the distal most part, distal few centimeter of this mesorectum is devoid, of the rectum is devoid of the mesorectum, and it is being encircled and covered by the levators and the puborectalis sling. And this is the part where the cancers would frequently involve these areas early because they are not being covered by the mesorectum. And so, all of us know that the evolution, the APR evolved from Cherney to Miles, and then, all these guys played a part in the management of rectal cancer, what we are doing today, to the point when, in 2007, Holmes decided and, threw some light that probably we're not doing the right thing because the wasting of specimen was happening, leading to tumor perforations, positive CRMs, and a lot of local recurrence. So, these are the reasons for poor prognosis of distal rectal cancers. So these are tumor-related factors that are higher T-stage and poor tumor biology, anatomical factors, as I discussed, and then this is the technical factors. This is the place where we can play our part, which is poor visibility during rectal mobilization, poor perineal exposure, and too economical resection for the intention of smaller wounds and closing the defects. So again, पहले हमारा ख्याल था कि APR का एक ही टाइप होता है, तो APR का एक टाइप नहीं होता, APR के बहुत सारे टाइप्स हैं. So this is a conventional or intersphincteric approach. Then there is the extra-levator APR, and you can tailor your extra-levator APR to the affected side of the levator. And then this is the horrible thing which is called as ischioanal APR, going right up to obturator internus and creating a very big defect. Most of this is needed in salvage resections in squamous cell carcinomas. So, जो मैंने आपको टाइप्स बताई, उन टाइप्स के लिहाज से ये सबसे ऊपर वाला स्पेसिमेन आप देखें, इसके अंदर काफ़ी वेस्टिंग हुई है. This is okay for a T1 lesion, probably, but this is not okay for those lesions who are really, really distal and T3 and T4. Probably this is the point where the perforation is going to happen. And this second is, this is the one towards your left is, the extra-levator APR with vaginal resection. This is a tailored APR to one side, and this, the top one to my right-hand side is the ischioanal APR with resection of a lot of ischiorectal fat because this was involved with the tumor. Again, APR and ELAP was, meta-analysis was done by Hong et al. In 2014, who compared, a total of 6 studies was included. One was an RCT, another was, a prospective study, and 4 were retrospective studies. And again, they compared the CRM involvement, intraoperative perforation, and local recurrence, and found out that extra-levator served better in all of these approaches. So in all of these studies. Okay, the same study continued. It clearly showed that the intraoperative tumor perforation, 3 years disease survival was overall better in extra-levator APRs. So what are the tumors that would warrant to have extra-levator approach? These are locally advanced distal rectal cancers, positive CRMs that would need extended resections, involvement of the levators, abutting distal vagina and prostatic capsules that can be resected and reconstructed. So this is the patient positioning. So this is modified Lloyd Davis for abdominal part and prone jackknife for the prenatal part. So this is my technique of doing it. So I do the abdominal part laparoscopic. So I use 5 ports. One is 12 millimeter, sometimes replaced by a 15 millimeter if I have used to, if I have to use that Panther stapler because it won't go through the 12 millimeter stapler, 12 millimeter port, and one is 11 millimeter port, and followed by 3 5 millimeter ports. So this is the abdominal part. So I, made it to go at 4x so that, I can cover. And these are all the surgeries I have done after completing my fellowship. So you retract the small bowel to your right, place a gauze to retract it, keep it retracted, and hitch the uterus to expose the, This was a long segment tumor starting at the peritoneal reflection going all the way down. So post-neoadjuvant, almost all of our patients are post-neoadjuvant, start of the mediolateral dissection. Find your plane. I think most of the dissection can be carried out by the hook. I hardly ever use, ligashores. I think most of 90% of my dissection is with the hook, other than, lateral rectal pedicles. So, you find the plane, hardly, any bleeding. You stay in the right plane, continue your dissection, dissect the inferior mesenteric artery and vein. You will find the nerves down there, preserve them, and clip the inferior mesenteric artery and vein. So, artery is being clipped. Sorry, I don't have the control, or I could have increased it to further speed. Vein is clipped. We will continue with the mediolateral dissection. It's not necessary to clip the vein that high. You can clip it in the distal rectal cancer. It's not really necessary to do a very high ligation. But again, the mediolateral plane is being completed. We'll do the lateral dissection, and then we'll go to the TME plane. So once the lateral dissection is almost completed, a suitable length is obtained to bring it out as a stoma. The colon has been mobilized, and then we'll start the posterior TME. Again, I would, at this point of time, I'll take the opportunity to say that if we are in the right plane, there is hardly any bleeding. So lateral demarcations, and then the interior TME followed by the lateral TME. So, the nerve has been clearly preserved on both sides. Again, I think though in open surgery, if we are careful, we can also preserve the nerves. But mere khayal ke mutabik, gone are the days of open surgery, and you can do a lot of better preservation of the urogenital and sexual function if you are doing it laparoscopic and robotic, because everything is under the VN. Rather than blindly dissecting with hand, I think we have to be very precise in our dissections. So I'll skip it to the, this is another patient showing a circumferential mesorectal excision. So extent of caudal dissection, we stop at the origin of the levators. We don't go down because this is going to result in the wasting of the specimen. Anococcygeal ligament is caudally reached. Stop there. Cervix and prostate anteriorly, and no coning should be done. At this point of time, we transect this sigmoid colon, bring it out as an end colostomy, and we'll do an abdominal wash, place a gauze down there to be facilitated, to be removed in the perineal portion, and momentum is brought out, is mobilized into the pelvis. So this is the prone jackknife position. ये मैंने 2 तस्वीरें इसलिए लगाई हैं कि शौकत खानम के पास बहुत फैंसी टेबल्स थे, बहुत अच्छा सब कुछ था, बट जब मैं बाहर आया तो ये 3 डिफरेंट पेशेंट्स की पिक्चर्स हैं One is Shaukat Khanam, the last one is probably so this is Lahore General Hospital, and the third one is probably Evercare. तो ये तीनों जगह के ऊपर मुझे काफ़ी तकलीफ हुई इसको पोजीशन को बनाने में, because the techs were not trained. So I used to take my tech who would bring this the patient into this position, but eventually वहाँ का staff भी सीख गया और ये सब कुछ करना possible था एक government hospital में भी और private hospital में भी. Again, this is the video of the perineal part which was done in a government hospital. So this is the extra elevator approach. I'm really sorry for the quality of video, but we tried to make it better. But one of the house officers was making it, so probably हम बहुत अच्छी quality की video नहीं बना सके. So we give a teardrop in CN, preserve the fat, go just lateral to the elevator muscles, and at this point of time we feel the coccyx, go right under the coccyx to open the fascia and find our gauze there, which will guide us for the further section. So at this point of time, you see the fascia has been opened, the gauze has been removed. For purpose of time, I removed it. This is the lateral limit of the dissection, just lateral to the sphincters, and preserving the fat of the ischiorectal fossa. And once this has been done, I would flip the specimen, the so-called somersault maneuver, and I already sutured the omentum to the end of the specimen that can be brought out easily. So now the specimen is out, and you see this has been, now I'm taking the elevators. This is the interior part of the dissection. This is the most easier thing, because interiorly the specimen is right in front of you. Either the vagina or rectum comes in front of you, and with all those positive interior CRMs, you can do an extended dissection right in front of your eyes, rather than doing it blindly in the lithotomy position. So you see, we carry on our dissection into the last part of the dissection is being carried on at the site of the inococcygeal ligament. So not inococcygeal, slip of tongue. So we use a combination of monopolar and bipolar current, and you see the specimen is almost out. So hardly any blood loss. We stay in the planes. Everything can be controlled. Okay, specimen is out. So these are the modes of pelvic floor reconstruction once the specimen is out. You can use mesh. You can use omentum. This is my preferred technique, because I do not have the liberty of those advanced reconstructions. We do it sometimes, but most of the time we use the combination of these two things. So this is the gluteus maximus flap reconstruction, intraoperative pictures, 7th postoperative day, and then 1 month post-surgery, a well-taken graft. So methods from January 2014 to December 2019, this study was done at Shaukat Khanam. I published it, and then I continued the numbers. And till date, I've been able to take it to 103 patients. My colleagues from Shaukat Khanam are continuing their data there, and I'm continuing it with me. So this is retrospective, prospectively maintained data, all patients undergoing ELAB during the same period. This is the published paper. So demographic variables, median age was 39 years, a total of 103 patients with male predominance. Again, most of the patients we dealt with were T3 and T4 lesions. And again, these are the operative variables. So mode of surgery, 103 patients, 1 conversion from laparoscopic to open approach. Again, because this patient was a victim of a bomb blast, and we found terrible adherence in the abdomen. It took us 2 hours to just do the adherent lysis. There was a bomb blast in Afghanistan. That was the reason, this patient had a laparotomy previously done. So other than that, all patients were laparoscopic, and most of our favored mode of reconstruction was omentoplasty. Again, only a minimal, I'll rush. And minimal, complications. Intraoperative tuber perforation were 6. And again, positive CRMs were 17. अगर हम इस डेटा को एनालाइज करें तो जो ज़्यादातर पॉजिटिव CRMs थे वो उस टाइम पे थे जब हमने शौकत खाना में काम करना शुरू किया था. Because these were more of related to patient selection. Because जब आप ये काम शुरू में करते हैं तो आपका ख्याल है कि आप सारे पेशेंट्स को कर लेंगे, then you only find out कि probably our patient selection was not good. But again, in the last 3 to 4 years, hardly any patient had a positive CRM. So we got better with our technique, and we got better with patient selection as well. So this is the perineal wound complication data. It was somewhere near 45%, so 44%. And again, most of these are wound infections that, correlated well with the international published data, but most of them, got better on conservative management. Dressing and antibiotics managed around 31 patients, and surgical debridement was needed in 9. 2 needed to have VAC, and time of a very sensitive marker to measure the outcome of your procedure is that this is the time to return to adjuvant chemotherapy. And believe me, this was around median time was around 5 weeks. So this is a univariate and multivariate analysis. I'll skip for time. And how do we compare? So if we compare it to a published data of perineal wound morbidity of extra-elevator APRs, we are almost at par with the internationally published data. So my journey from SKM to my practice, so operative time, जो median था हमारा वहाँ पे 320 minutes था, my operative median time is currently 300 minutes, and blood loss is around 50 to 70 ml, and intraoperative tumor perforation and CRM almost correlate to what I was doing at Shaukat Khan. So these are the specimens. Dr. Amjad हमेशा कहते हैं कि let the specimens speak your work, because इसीलिए हम we can all say we are doing good work, but let the specimen speak our work. This is a tailored APR, extra-elevator APR, taking more tissue on one side. This is the resection cavity, clean cavity. And again, you can see this is, I have mentioned the histopathology results on the top, clear margins, R0. Another specimen, anterior and posterior specs of the same specimen, cylindrical specimen. And again, PT4, but clear margins, a small vaginal cuff resection. This is the ischioanal APR after salvage resection for squamous cell carcinoma post-chemo radiation failure. Again, are not clear margins, resection of the prostatic capsule along with it. Again, a cylindrical APR, again with the resection of complete anterior posterior wall of vagina and reconstruction. You can see this is the resected vaginal cavity. I have marked with blue ink, and then this was reconstructed in this way. Again, clear margins. Again, this is a cylindrical APR that was performed. Vaginoplasty was done. Posterior wall of vagina resected. Again, clear margins. Another 2 specimens with extra-elevator APR. The one towards my right is a recurrent rectal cancer, post-recurrence for low anterior section, and again done in the the similar fashion. Again, clear margins. So this is the resection cavity. Again, a tailored APR, resection more on the one side. Again, clear margins. So the last 2 specimens, again, the right is a horrible tumor. You can see down the tumor was ulcerating through the whole skin, and again, clear margins. So the benefits of ELAP technique is decreased intraoperative tumor perforations, decreased positive CRMs, decreased local recurrence, and I think a better overall survival, better VN and ability to do extended resections, decreased blood loss, because everything is in front of you. So why is this a little problematic? Why is not everyone adopting to this technique? So logistic or technical issues दोनों हैं इसके अंदर. Time, of course, patient को prone करने में, position change करने में थोड़ा सा time खर्च होता है. Again, positioning में problem आता है, team training, anesthesia की training की ज़रूरत है, OR training की ज़रूरत है, क्योंकि patient के जो mechanics हैं, respiratory mechanics and physiology, सब कुछ change हो जाता है once you make the patient prone. So OR training, nursing, doctors, everyone needs to be trained. Possible injuries during proning. हमने कुछ injuries भी देखी हैं prone करते हुए. But again, everyone has to be on one line before you're treating them. Wound morbidities की थोड़ी सी ज़्यादा है because cavity बड़ी है, reconstructions की ज़रूरत है, and you spend extra time on that. Conclusion: ELAP is an excellent way of dealing with locally advanced distal rectal cancers. Results in decreased intraop tuber perforations, results in better CRMs, decreased local recurrence, has significant wound morbidity, and needs proper training and learning curve, and shall be used judiciously for appropriate cancers. So these are my mentors, and I say if I have seen further, it is by standing on the shoulders of the giants. And thank you very much. So if there are any questions, I'm happy to take them.
Questions from the audience? Dr. Raza has something to say. Can you have the mic?
You said you improved after patient selection. What is the criteria? Was it your first personal experience or?
Yeah, I think that is better training, and then sitting with the radiologists who are trained in the reporting of the rectal cancers.
I mean the MTD was?
Yes. And specifically we need those people who are trained in reporting rectal cancers. So they would tell us this is the place where you have threatened margin. कई दफ़ा हमें patients को second line chemo भी लगवानी पड़ती है. So I think better patient selection is the key to have a good outcome. So अभी अगर हम अपने last कुछ series को observe करें, तो we were always we have a dedicated person who would report rectal cancers. और मुझे नहीं लगता कि शायद ही कभी हमें कोई मसला हुआ हो जब मतलब इस पिछले 3-4 साल के अंदर. So this is the better tumor board, this is better training of everyone and then getting better outcomes.
Dr. Raza.
Thank you very much, On. I think you have promoted this technique very well, but I would rather say that it is how you have adapted and executed this technique in your setup and persisted, that has resulted in the improved outcome. So training and how you executed all these procedures, and kudos to you for doing that. Thank you.
I think this is kudos goes to my mentors, I think.
May I say something, please?
Yeah, sure, please, sir.
In your all lower rectal cancer practice, do you adopt these procedures?
No, I am selective.
So how much percentage of your cases?
I think this is 50-50. I am selective. If this is a a mobile lesion, good response to chemo radiation, I'll go for a standard APR.
Okay. Second question is that the gap you filled by the gluteal flaps, who does the operation?
Gluteal flap हम लोगों ने सिर्फ इसमें एक किया है. ये मैंने उसकी पिक्चर दिखाई थी आपको. ग्लूटियल फ्लैप करने का प्रॉब्लम क्या होता है कि the plastics has to be on board, और plastics जो है वो they take another 2 to 3 hours to do that, and in a patient who is already anesthetized for this while, probably हमारे logistics अभी उतने improve नहीं हो सके. We are working on that. So most of the times what I do is we construct it with omentum. We mobilize the omentum, take it down to the pelvis, anchor to the levators, and probably we had only one perineal hernia on our follow-up.
Okay.
So most of the times we get away with it.
Third thing.
Yeah.
So 50% wound complications.
44%.
Yeah. So it's nearly about 50-50.
Yeah.
Every second patient has got a problem with the wound.
Okay.
And that increased a lot of problem in the post-op phase.
I'll explain that. Firstly, all of these patients were uniformly radiated. 100% of these patients had radiation. Some of around 80% of them had a long course CCRT, followed by around 20% of them had like short course radiation protocol. So radiation के बाद जब आप maximum dose of radiation patient को दे रहे हैं, उसके बाद wound healing की capacity वैसे ही कम हो जाती है. तो perennial wounds आप conventional को भी अगर compare करें, तो there are even studies who saying कि conventional APRs की और accelerators की perennial wound morbidity तकरीबन एक जितनी है. I agree कि इसके अंदर infection ज़्यादा है क्योंकि cavity भी बहुत बड़ी है. Then this is uniformly radiated. But again, then अगर आप subsequent data को देखें तो उसमें ये बताया गया कि most of them settled. They had some mild infection, but most of them settled conservative management.
और मुझे आपसे ये पूछना है कि जो स्फिंक्टर सेविंग सर्जरी है
जिसमें डॉक्टर चीमा
सॉरी मैं आपसे ये पूछना चाह रहा था जो स्फिंक्टर सेविंग सर्जरी है तो आप उसको ये जो आपने APR सेलेक्ट किए हैं if was any one patients could have the sphincter saving?
These were all those who were involved with the sphincters. We breach all, get in all the boundaries we use
has been crossed
to go, to save the ultra low interior sections. We will do them. Agar kisi jagah patient ka ho sake, we would do them. But these are all those who had involvement of the levators, external sphincters, and they were all candidates of APR. इसमें से कोई भी ultra low या low interior section का candidate नहीं था.
नहीं था. Thank you.
Professor Amjad.
सबसे पहले तो fantastic. This is the word that comes to mind. It's excellent. What you have achieved, or congratulations for that.
Thank you.
This is comparable to anywhere in the world, probably better than most. वो सर्जरी देख के तो लग रहा था कि मुझसे बेहतर है. So well done.
जी सर आपसे बेहतर है.
हाँ तो second thing ये है एक comment है और एक suggestion है. मतलब John perhaps एक suggestion ये है कि low rectal cancer, particularly abdominal perineal excision, not necessarily within this country, generally around the world, is done very badly because most of the time top end is done by the senior guys and the bottom end is left in thoughtful position for the junior registrar to finish it off as it is. So that is the fundamental problem where people sort of get maximum local failure, local recurrences. तो मेरे ख्याल में तो this technique जो आपने दिखाई है, इसकी education platform को इसको use करना, this is going to make a huge difference in cancer care in this country. क्योंकि इसमें फैंसी इंस्ट्रूमेंट्स की ज़रूरत नहीं है, इसमें सर्जिकल ऑन्कोलॉजी की, बेहतर रेडियोलॉजी की और परहैप्स इनसाइट की ज़रूरत है, जो आई एम प्लीज टू से कि आप लोगों में काफ़ी ज़्यादा है, यू रिफ्लेक्ट. तो सजेशन मेरी ये है कि परहैप्स यू शुड रन एजुकेशनल इवेंट फॉर डिस्ट्रिक्ट सर्जन्स कि जो इन चीज़ों को तो नहीं पहुँच सकते लेकिन APR तो करते हैं, रेक्टल कैंसर तो डिस्ट्रिक्ट में भी ट्रीट होता है. इट वुड मेक अ डिफरेंस. लगता यही है कि इसके करने से कुछ नहीं होगा, लोग आपको यही बताएंगे. एंड यू आर अ परफेक्ट एग्जांपल ऑफ परहैप्स कमिंग फ्रॉम अ सेटअप कि जिसके बारे में जनरली इंप्रेशन ये है कि जी उनके पास तो सब कुछ है, जब गवर्नमेंट में आएंगे ना तो लगेगा पता. तो आपके पास क्या जादू की छड़ी है कि आप गवर्नमेंट में भी आए और आपने वो सब कुछ कर.
सर मेरे ख्याल के मुताबिक अगर आप मेरी स्लाइड के लास्ट, कैन यू प्लीज प्ले द लास्ट स्लाइड, जस्ट नंबर.
इट्स ओके, यू कैन टेल मी.
मैंने उसके अंदर जब मैं फेलो बन के फेलो से एक कंसल्टेंट के तौर पे आया तो उसके अंदर जो मेरी सबसे बड़ी सपोर्ट थी, दैट वाज माय प्रोफेसर. सो आई वुड पे ऑल दिस क्रेडिट टू द मैन सिटिंग ऑन माय राइट. सो ही सपोर्टेड मी. उन्होंने मुझे, बिकॉज उनका सबसे बड़ा प्रॉब्लम था, ही वाज आल्सो एप्ट एट ऑल दीज थिंग्स. सो उस वक्त मैं सीनियर रजिस्ट्रार था, फिर मैं प्रमोट हुआ, मैं AP बना. बट एट द सेम टाइम दिस इज द गाय, after Dr. Shaw, all these 3 other people, he supported me to do all these things. It took me 2.5 years to implement everything in my ward. So, हमें ज़्यादा चीज़ों की ज़रूरत नहीं है. मैं हमेशा कहता हूँ APR करने के लिए एक L-hook चाहिए और एक लाइगाशोर चाहिए, जो कि आप कॉस्ट डिवाइड कर सकते हैं. आप यकीन करें मैंने सारी चीज़ें अपनी खरीदी. मेरे पास लैप्रोस्कोपी के सारे अपने इंस्ट्रूमेंट्स हैं. एंड वी स्पेंड एवरीथिंग ऑन द पुअर पेशेंट्स. अगर एक पिछली दफ़ा कोलोकॉन पे मेरे से सवाल किया गया था कि जी आपकी एवरेज पेशेंट कॉस्ट क्या आती है, तो आज मैं एवरेज पेशेंट कॉस्ट कैलकुलेट करके आया हूँ. सो गवर्नमेंट सेटअप के अंदर मेरी एवरेज पेशेंट कॉस्ट, अगर तो पेशेंट मुझे दे दे, वो मतलब हॉस्पिटल मुझे स्टेपलर्स दे दे, तो दैट इज़ फ्री ऑफ कॉस्ट, एवरीथिंग इज़ फ्री ऑफ कॉस्ट. बट अगर हॉस्पिटल ना भी दे और कॉस्ट खत्म हुए हों तो अराउंड 35,000 to 40,000 रुपीज़, जो कि पेशेंट को एक गन जो कि हम शेयर करते हैं 6 to 7 पेशेंट्स के ऊपर, और उसके बाद एक लाइगाशोर है जो हम अगेन शेयर कर लेते हैं, और एक रीलोड चाहिए. एंड ऑल इट नीड्स टू डू इज द विल. अगर ये विल मौजूद है, और अब मैं हूँ, अवैस है, वी आर लाइक 5 people सर्विंग इन अ गवर्नमेंट सेक्टर हॉस्पिटल्स, और हम सब कुछ ये कर रहे हैं. वी आर ट्राइंग टू गेट अटेंशन कि किसी तरह हमारा प्रोग्राम रिकग्नाइज हो जाए. अभी तक हम कामयाब नहीं हो सके, पर आई होप के
इसको ज़्यादा देर नहीं लगेगी. आई एम श्योर पीपल वुड सी द लाइट. तो बॉटम लाइन ये है कि विजन चाहिए
जी,
और ये डर निकल जाना चाहिए कि ये मुझसे बेहतर हो जाएगा, मेरे डिपार्टमेंट में आया है.
सर वो तो डर है ही,
बस
अल्हम्दुलिल्लाह.
बहुत शुक्रिया.
थैंक यू सर, थैंक यू वेरी मच.
Thank you, Dr. On.
So thank you, Dr. On, for a very nice talk. And I would like to thank the audience for being part of this session. And any comments from my panel of experts?
I just had a comment. Thank you, Dr. On. That was a very nice presentation. I congratulate you on your technique and your ability to do these in difficult circumstances. I would have congratulated you even more if you had given us data on long-term follow-up. Unfortunately, for most of us, these surgical conferences have become a display of surgical technique and the immediate perioperative outcomes. For cancer care, it is not our technical expertise which is important, but the long-term outcome for the patient. This, I'm not saying as a criticism, this is a problem in our environment. Most of the data that is generated locally, even long terms, like I noticed you started in 2014 with your case series, we don't seem to have long-term data results. And that is something I would like us to think about and present. Thank you. Wonderful. So, excellent. So that's what I thought we could have done with hearing from about that as well, because technique is one, and the longer term outcomes is what is important to the patient, and is really what it's all about. Thank you.
All right. Thank you, my panel of experts, and I would like to conclude this session and hand over
May I
back to the
conclude
computer.
the session?
Yeah, please.
I think we had a very good session, and I would like to thank all the speakers. Dr. Rao, you have enlightened us. You have told us the challenges of laparoscopic surgery in Pakistan, and you're doing colorectal surgery, and there is a lot to learn from your experiences over here. Dr. Cheema, who is a master trainer, is a trainer of a trainer. He always enlightens us when he's here, and there's always a lot to learn from him. Dr. Kamal Arfin, he's a great friend, and he's a great endoscopist, and he always there to help us in doing EMR and difficult cases, so we rely on him when we are stuck up. Dr. On, thank you for giving a very good presentation. I think we surgeons are hesitant because we are used to keep putting a patient in a Lloyd Davis position, but once you turn the patient, the life becomes a lot easier, because I've been doing some surgery in jackknife position, and then you see it directly over there. Operation is much easier than, and it is under vision rather than most blind in the Lloyd Davis position. So there is a lot to be said about it, and I think we should learn to adopt it. Thank you very much.
Thank you, Dr. Omer. Now I would like to request panel of experts to remain on the stage.
Now, ladies and gentlemen, I am pleased to invite Professor Sajda Qureshi, one of the leading female general surgeons of Pakistan. She has specialized in upper GI, bariatric, laparoscopic and robotic surgery. Ma'am, please come on the stage and distribute the certificates of participation among the panel of experts, speakers and moderator.
Professor Shafiqur Rahman, sir, please can you come forward and receive your certificate of participation. Dr.
Professor Mohammad Zubair, please sir come forward and receive your certificate.
Professor Razak Sheikh, sir, please come forward and receive your certificate of participation.
Professor Inam Pal, sir please.
Professor Irfanul Islam, sir, please can you come forward to receive your certificate?
Thank you, our esteemed panel of experts. Now I would request Dr. Khalid Rao, speaker, to come forward and receive your certificate. Now I would request Professor Amjad Parvaiz Cheema to come on the stage and receive your certificate, sir, please.
Professor Kamarul Arfin, sir, please come and receive your certificate of participation. Dr. On Jamal, sir, please come on stage and receive your certificate of participation.
Now I would request Dr. Omer bin Khalid, the moderator of this session, to please come forward and receive your certificate.
Thank you, Dr. Sajda.
Thank you, ma'am.
Now it's time to formally inaugurate this ceremony. For that, we feel honored to have with us Honorable Founder of Colorectal Disease Patient Welfare Association, the Meritorious Professor of Surgery, Professor Amjad Siraj Memon, Vice Chancellor, Jinnah Sindh Medical University, Karachi. He has previously performed duties as a Chairman and Dean of Surgery at Doha University of Health Sciences, Principal of Doha Medical College, and Head of First Dedicated Colorectal Surgical Unit in Civil Hospital, Karachi. Sir, you hardly need any introduction. We feel immense pride to invite you on stage. Please give a warm welcome to Professor Amjad Siraj Memon.
Bismillah ar-Rahman ar-Rahim. Distinguished guests, faculty members, students, residents, doctors from the community, members of the pharmaceutical industry, Assalamu alaikum. I really can't tell you how I feel today, especially after this. Since I have moved out of Doha, I never thought that they'll be, arranging a better conference than we used to do together. And so it's basically naam mera use hua hai, lekin effort sara Khurshid, Rabia and in sari company jo hai. Or I'm especially grateful to Professor Tahsin Qureshi and Amjad Cheema साहब कि जो वो हमेशा हमें oblige करते हैं, हमें सिखाते हैं और हमारे लेवल पे आके सिखाते हैं. एक ये आर्ग्यूमेंट अभी आज डॉक्टर इनाम ने जो एक पॉइंट रेज किया, तो यस I am a reviewer of one of the journals of surgery, World Journal of Surgery. So I got a article that they were using. This was an Australian university affiliated hospital in a very rural area of Nicaragua. वहाँ पर वो स्टडी हो रही थी, वो थी ऑस्ट्रेलियन यूनिवर्सिटी की छतर छायाओं में. They were using mosquito nets. Sir, they were using mosquito nets for as a mesh repair because they hadn't the resources, so and they hadn't the money, so they अपनी एक उन्होंने इख्तरा की कि उसमें मॉस्किटो नेट को उन्होंने ऐसा ट्रीट करवाया अपने फार्मास्यूटिकल कंपनी से कि वो उसमें रिएक्शन कम से कम हो, कोई इन्फेक्शन ना हो, ये ना हो, वो ना हो. तो मुझे अपना मुल्क याद आया कि हमारे पास मॉस्किटो नेट ही नहीं है लोगों के पास फ्लडेड एरियाज़ में. वो तो बाद में मॉस्किटो नेट को हम मैश तो बाद में बनाएं, हमारे लोगों के पास तो ये भी नहीं है. लेकिन साथ साथ हमारे पास हमारे ऊपर अल्लाह ने ये ज़िम्मेदारी भी डाली है कि न सिर्फ उनको केटर करें मगर हम अपने जो मरीज़ हैं, वी नीड टू डेवलप आवर सिस्टम्स in a way that we compete with the world and we make services of an international standard, surgical services of international standards available to people here. Alhamdulillah, we have done well. I got the idea of starting this COLOCON from a colleague of mine वो जहाँ पे भी होता है वो उसको बताने की ज़रूरत नहीं पड़ती कि शमीम कुरैशी यहाँ मौजूद है। वो कहीं ना कहीं से कोई लतीफ़ा भेजेगा और पता चल जाएगा कि अभी आपने क्या कहा कि अमजद साहब के लिए कहा ना कि क्या एंट्री मारी है, ये शमीम कुरैशी के अलावा किसी की मजाल नहीं है। तो he used to arrange a colorectal conference for a whole week, operating kind, और उसमें फिर कंसल्टेंट कॉर्नर हुआ करता था जिसमें डिफ़िकल्ट केसेस दे यूज्ड टू डिस्कस विद वर्ल्ड अथॉरिटीज़, रियली वर्ल्ड अथॉरिटीज़। ही नेवर वेंट फॉर जो नंबर 2 सर्जन्स। कल इन्होंने मुझे एक बताई अमजद चीमा साहब ने कि पीटर ज़ोलॉफ, राइट, पीटर ज़ोलॉफ इज़ अ रशियन सर्जन, और ये जब उनसे मिलने गए तो उन्होंने कहा कि आई एम द नंबर 2 सर्जन ऑफ रशिया। तो ऑटोमेटिकली बनता है ना कि सवाल तो बनता है कि भाई फर्स्ट फिर कौन है, तो उन्होंने पूछ लिया कि फर्स्ट कौन है, तो देयर आर मैनी अराउंड। सो यहाँ पे जो है हम तो 2 नंबर के लोग हैं, दूसरे ग्रेड पे, यहाँ पे बहुत सारे फर्स्ट नंबर्स होते हैं। आई एम सबसे ज़्यादा डिलाइटेड कि इतने सारे लोग जो इकट्ठे हुए हैं आज, दे आर heads of institutions themselves. They are institutions in themselves, really. And gathering all of them here is really not a mean feat. And abhi I was talking to one of the guys there कि देखो पाकिस्तान सोसाइटी ऑफ गैस्ट्रोएंट्रोलॉजी है, पाकिस्तान सोसाइटी ऑफ हेपेटोलॉजी है, पाकिस्तान सोसाइटी दिस दैट, ऑर्थोपेडिक एसोसिएशन, ये सारी हैं जो कि कॉन्फ्रेंसेस कराती हैं और वो उसमें अटेंडेंस भी उनकी होती है। लेकिन हमारा तो एक वार्ड है, वी आर नॉट अ ऑर्गेनाइजेशन एज सच इतनी कोई बड़ी, सिर्फ एक यूनिट ने इतनी मेहनत की है हमारे बच्चों ने कि उनके लिए, उनकी एप्रिसिएशन में, उनकी दोस्ती में, उनकी मोहब्बत में, उनके काम को देखने और अपना काम शेयर करने अच्छे अच्छे लोग आए हैं। मतलब यू नेम द हॉस्पिटल, यू नेम द यूनिवर्सिटी जिसका आदमी यहाँ नहीं बैठा हो, प्रोफेसर और हेड ऑफ डिपार्टमेंट्स, तो इट्स रियली एन ऑनर। मुझे आज और एक और बात की खुशी है कि हमने जो, अल्लाह का शुक्र है, किसी तफरीक के बग़ैर रेजिडेंट्स को जितना भी ख्याल रख सके, माय रेजिडेंट्स एक्चुअली लव मी फॉर दैट एंड आई एम वेरी ग्रेटफुल। कल एक लड़के ने तस्वीर शेयर की, शफीक साहब, कि एक ब्रांड न्यू करोला के ऊपर टेक लगा के खड़ा है और कहता है कि आई हैव परचेज दिस कार। अब करोला आज के यहाँ 50 लाख के करीब जाके पहुँची है, उसको 2 साल FCPS को हुए हैं, लेकिन वो सियाना था जो मेरी एडवाइस ली उसने। मैंने कहा जहाँ ही बिलोंग्स टू उमरकोट, एंड मैंने उसको कहा था कि यहाँ जो तुमने स्किल सीखी है ये दिस इज़ एक उधार है तुम्हारे को, तुम्हें अपनी कम्युनिटी को यू हैव टू गिव इट बैक। एंड ही वेंट एंड ही इज़ ऑल्सो डूइंग लैप्रोस्कोपिक वर्क देयर, ही इज़ डूइंग अ गुड जॉब। जहाँ मुश्किल में पड़ता है रेफ़र, ही नोज़ कि कहाँ पे मेरी, वहाँ पे हॉस्पिटल्स छोटे हैं, ICU नहीं है, उसकी जो जहाँ पे लिमिटेशंस हैं वो उसको समझ में आ गई है। और मेरे ख्याल में ये बहुत बड़ी बात है। मेरे ख्याल में टू रेफ़र इज़ अ मच बेटर थिंग टू डू। एंड मैं कल डॉक्टर तहसीन से बात कर रहा था कि किस तरह इन लोगों के पास इंटर डिपार्टमेंटल रिफरल है, एंड ही वॉज टेलिंग अस अ लॉट ऑफ द वेज एंड मीन्स इनके हॉस्पिटल रन करते हैं। ऑफ कोर्स मेरा थोड़ा एक्सपीरियंस है, लेकिन बच्चों को बता रहे थे। तो अब एक उमरकोट एक तरफ रह गया, तो दूसरी तरफ हमारे एक डॉक्टर वारिस है, वो पता नहीं कहाँ दूसरी एंड का है, कश्मोर कंदकोट का। फिर एक और है जो हमारे कराची के जो टॉप क्रीम बच्चे हैं, वो अल्लाह का शुक्र है कि अब एसोसिएट प्रोफेसर बन गए, प्रोफेसर बन गए। तो जब वो मुझे फ़ोन कर रहे हैं मैं प्रोफेसर बन गया, तो मुझे बड़ा खुशी तो होती है, लेकिन मैं अपनी एज का अंदाज़ा होना शुरू हो जाता है कि चलो ये लोग प्रोफेसर हो गए, स्टूडेंट्स भी हमारे। तो आई एम वेरी ग्रेटफुल टू ऑल ऑफ़ यू। लेकिन एक जब जहाँ पे खुशियाँ होती हैं वहाँ पे अपने हिस्से के गम भी होते हैं। तो मेरा एक रेजिडेंट जो है दिलीप, he met an accident and he became quadriplegic. He was a serving district surgeon in Mithi. He also chose to go back and he was serving his community. Unfortunately, he met an accident. But we have not left him. He has regained his confidence, and we have offered and he has accepted, and he has started coming to our unit as a research fellow. His FCPS was within the first attempts, and he worked in various capacities. I would like you to give him a big hand. It was only the last conference, 19, हमारी जो कोविड से पहले की थी, उससे पहले मैं गया था for a workshop in Vietnam. So वियतनाम में मुझे जो चीज़ें नज़र आईं, उसमें एक चीज़ वूंड प्रोटेक्टर जो उन्होंने बनाया, वो हर जगह पे मिलते हैं, बाज़ार में काफ़ी इंडस्ट्री ने अवेलेबल करके दिए, बड़े महंगे पड़ते हैं वो. हमारे मुल्क में जहाँ पे क्लिप्स लेने के लिए दुश्वारी हो रही होती थी, तो उसने जो है एक एनजी ट्यूब काटी, उसके ऊपर जो स्टेराइल सर्जिकल ग्लव है वो चढ़ाया, और एक सिल्क बांधा, एक तरफ दूसरा सिल्क बांधा, उसको ट्विस्ट किया, बिल्कुल एग्जैक्टली द वे द वूंड प्रोटेक्टर्स, इट्स अ स्टेरिलाइज्ड थिंग, यू मेक इट देन एंड देयर. सो मैं सीख कर आया, मैंने इनको सिखाई. प्रीवियस कॉन्फ्रेंस में ही वॉज द वन हु डेमोन्स्ट्रेटेड इट लाइव टू द ऑपरेटिंग वर्कशॉप, और इस मरतबा इसने एक वीडियो बना के दी है जो कि इस कॉन्फ्रेंस का हिस्सा बनेगी. आई वुड लाइक टू प्रोफेसर तासीन कुरैशी and Amjad Cheema Sahab to please award him a certificate. So, Dilip is now teaching medical students and also doing जो भी research हमारे unit की अब हो रही है. He filters that, collects the data, उसका computer section जो है वो उसको ये supervise करता है. And I am very grateful, Dilip, for all you are doing for us. आप इनको please नीचे ले जाएं. हम लोग इस दुनिया में थोड़े दिनों के लिए आए हैं, ये हमें याद रखना चाहिए, और जितना टाइम आए हैं उतना हम अपनी तरफ से कंट्रीब्यूट करें. और मैं अगेन बहुत शुक्रगुजार हूँ कुरैशी साहब और चीमा साहब का कि जिन्होंने अमंगस्ट अदर गेस्ट ऑफ कोर्स कि ये स्पेशली हमारे लिए चल के आए और सुबह 6 बजे पहुँचे और 10 बजे ऑपरेट कर रहे थे. तासीन साहब भी, और मुश्किल केसेस इस मरतबा पता नहीं क्यों इन्होंने सिलेक्शन अच्छी नहीं थी, तो कुरैशी साहब के साथ उन्होंने बड़ी ज़्यादती की है, बहुत मुश्किल केसेस उनको दिए. और असिस्टेंट अच्छे थे, आप ये कह रहे हैं दिल का जला क्या कहेगा. सो एनी हाउ आई एम वेरी ग्रेटफुल. अब मैं मेरे और मतलब आपके और चाय रिफ्रेशमेंट के बीच में सिर्फ एक शेर है. मैंने रिसेंटली सुना था, मैंने पल्ले से बांध लिया है. अगर ये बात आपके सर में घुस गई तो आप खुद ब खुद सर्विस मोड में आ जाओगे. वो मैंने एक अखबार में पढ़ा था, एक बिल्कुल ही इनकॉन्स्पिक्यूअस अखबार में, और पता नहीं क्यों मुझे पसंद आया. मैंने 2-4 दोस्तों से शेयर किया, उनको भी पसंद आया, तो मैं उसको चाय पे जाने से पहले पढ़ूंगा कि छत को छत होने पे बड़ा गुरूर था. छत को छत होने पे बड़ा गुरूर था हारिस. छत को छत होने पे बड़ा गुरूर था, एक मंजिल और बनी, छत फर्श हो गई। तो आज हम जहाँ पर जिस मेंटल पे खड़े हैं, कल वहाँ नहीं होंगे, कल कोई और खड़ा होगा, ठीक है। लेकिन जिस मेंटल पे हैं उसका तकाजा, उसके तकाजे हैं, वो पूरे करने ज़रूरी हैं। आप लोगों का बहुत बहुत शुक्रिया। लेट्स हैव टी टुगेदर। यस फरा। हाँ, लेकिन छत बहरहाल फर्श बन गई। थैंक यू।
Now I would like to request Professor Amjad Siraj Memon to give token of appreciation to Professor Amjad Parvaiz Cheema.
And I would like to invite on stage Professor Tehseen Qureshi. He is a consultant general surgeon at University Hospitals Dorset in the UK and visiting professor at Bournemouth University. He is also running international laparoscopic master classes. So please come forward. Thank you, sir, for being with us. Your presence is an honor and a source of encouragement for all of us. After this session that was full of enthusiasm and valuable knowledge, it's time to boost ourselves for the upcoming session. So I would like to request all the guests to proceed for a tea break. We will resume after then.